Rima, when you want, you can start.
Hi guys, sorry, I lost the connection. I'm back.
Okay. So when...
Okay, I think we're open. So, Hi everybody, welcome to Congenital Heart Academy and welcome to this amazing series. And I want to thank again the amazing speakers that we are going to have today and Dr. Rima, who is organizing these meetings. And I'm sure everybody is learning a lot with them. So just before Dr. Rima starts to introduce our speakers and the theme of the day, I just want to share a quick video about the World Congress that we want to invite all of you to save the date and to be with us. So guys, please save the date. It's going to be next year, end of August, beginning of September. It's going to be amazing. So Rima, now it's with you. Thank you guys. And please type your questions on a Q&A chat box. These amazing speakers are going to be able to answer the questions in the end of the session.
Okay, thank you, Grace. Welcome again to our 17th webinar on the Fetal Cardiology series under the umbrella of Congenital Heart Academy. And I'd like to thank all the support we're getting from the Congenital Heart and from the whole world and the speakers that really honor us by talking to us and teaching the whole world fetal cardiology. We have a lot of followers on the YouTube, and if you cannot join us today, you can just join us on the YouTube and under Congenital Heart Academy fetal series. Today, we are going to talk about a very important topic. It's fetal arrhythmia revisited. And this is really very important for all our viewers, whether they are fetal cardiologists, whether they're primary care, whether they're fetal maternal specialists, nurses, echo technicians, and students, and so on. Our first speaker, we're very delighted to have Professor Lisa Holmberger. And Lisa was my previous mentor many years back, but the most important thing, she's the founder and until recently past director of the Fetal and Neonatal Cardiology Program and current section head of pediatric echocardiography. She's the professor of pediatric division of cardiology and obstetric and gynecology at the University of Alberta and Strawley Children's Hospital, Edmonton, Alberta. For nearly 3 decades, she's been involved in the clinical and educational research and problems and projects in fetal and neonatal cardiovascular health and disease. We all know that she's a very good publisher. She published over 180 peer-reviewed articles, over 250 abstracts, and she co-authored textbooks. One of them is our bestseller, the Perinatal Cardiology Handbook by Elsevier and Mosby, and it's problem-based, and we are hoping to get the second edition out to the public soon. So Lisa is going to tell us the tips and tricks of how to diagnose fetal dysrhythmias. And we know that we cannot go really, we cannot diagnose unless we follow the instructions of how to have the clinical sense and the vision and the training to read the fetal echoes properly and get proper history on the case. Lisa, please go ahead. Thank you.
Great. Thank you, Rima, so very much for the invitation, and I am really honored to be able to present this topic, which is one that certainly is important in our field. So I'm going to start with just giving an overview of our techniques for diagnosing fetal arrhythmias. Our echo-based techniques, which this topic and this talk will actually focus on, include M-mode, pulse Doppler, and of the pulse Doppler, we have LV inflow, outflow, SVC and ascending aortic flow, pulmonary vein and pulmonary artery flow, and then tissue Doppler. Of course, all echo-based techniques are really more flow and mechanical and don't really actually measure the electrophysiologic events. We infer these events from our flow and mechanical events, giving us information about atrial and ventricular contractions. So it takes us a bit to understand exactly how you use this data to make a diagnosis, which we're going to cover today. Certainly, Dr. Strasberger and her colleagues have really been on the forefront of developing the use of magnetocardiography in this area and fetal ECG, as well as increasingly being used and modified, and it will eventually hit mainstream for programs in time. And both of these actually provide true electrophysiologic events that we're really looking forward to ultimately be able to do these techniques in our practice. So with respect to echo diagnosis, M-mode is certainly one of the technologies or modalities that has been out there for a long time.
Lisa, can you speak up a little bit, please?
Sure. It's one of the simplest. I don't know. Can you hear me now? It's one of the simplest techniques to use, and it's certainly good for most arrhythmias. This is just an example. I usually try to go through the right atrium, and then either the left ventricle will show you the right ventricle. You're not looking for something perfect. You're looking for something that just gives you wall motion, and the right atrium is more tuberculated, so it's easier to see. Sometimes the right atrial appendage can be very useful, and then it's catching one of the ventricles. And so in this way, you're seeing atrial contraction, and I've outlined it a little bit to really make it clear, along with ventricular contraction, and you have AV, 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 in keeping with a baby with a normal atrial rhythm. And if it's a rate of 140, it's probably sinus. And this is good for really diagnosing most arrhythmias, as you'll see. But there is a caveat. So this is just showing you getting your M-mode cursor placed through the right atrium and more of the right ventricle, or you can even go through the right AV junction right on the edge to get the AV contraction, AV, and really see that AV synchrony is present and consistent and at normal rates against sinus rhythm. The problem is I find it really difficult to measure intervals. So while it's really quick and easy to capture and get a general sense of a diagnosis, measuring intervals is nearly impossible really to know exactly whether you're right on. This is another technique of pulse Doppler, LV inflow, outflow. You're basically placing your cursor somewhere between the LV inflow and outflow, as you would do for things like IVRT, measuring isovolemic relaxation time. I often will slightly widen my sample volume to really capture both inflow and outflows, but you have to be careful because the wider it is, the more you're going to sample everything. And in a small heart, it may be too much. So it gives you an inflow that's biphasic in most, and of course with the tachyarrhythmia it might not be biphasic. You have an early E, and then during the early part of ventricular diastole, and then an atrial contraction, and that atrial contraction is going to be key for looking as an example for what's happening with what's happening between atrial contraction and ventricular contraction and the synchrony. So this is A, and this is the ventricular outflow. And what we'll see is this is actually really helpful for measuring intervals. Not perfect though, and especially in tachyarrhythmias can sometimes be difficult. And it's not great for all arrhythmias. I will tell you that especially things like premature ventricular contractions, you can actually be fooled in thinking that they're PACs. So one has to be very careful and really document using other modalities. But it's helpful for AV interval and monitoring of AV intervals, for instance, in a baby that's at risk for AV block. So what we're seeing is an inflow start of the A wave to the start of the V wave, and that's the mechanical PR interval or AV interval. And there's normative data that's been published by several groups, but one of the nicest is that out of Toronto, demonstrating what happens with AV intervals with time and providing normative values. Spc Ao Doppler actually took me a long time, I have to be honest, to learn how to do it and to do it well. It took me probably about 2 years, I'm very embarrassed to say. I used to listen to Jean-Claude, who described this technique, and he would just show it. It looked so easy, but it's not so easy. However, it is probably the best one that we have from a Doppler perspective or from a pulse Doppler perspective. What I usually do is try to go very low in the fetus or very high, even up towards the shoulder, because what you're trying to do is get as parallel to flow between the AO and SVC, and it takes advantage of their juxtaposition. And what I'm doing is putting my cursor right through between the SVC and AO, and I can widen that a little bit, but again, you don't want to sample too much, it gets messy. And then what I'm going to get is a tracing of forward flow in the SVC, a little A wave reversal, and then you're seeing the reversal or the antegrade flow through the aorta here. So the A wave and the aorta heading in the same direction, and that is away from the heart, and that's going to be very helpful. But if you're not parallel to flow, getting the actual A wave is very, very difficult because those velocities are very low. So you have to be parallel to flow, with the exception sometimes of Hacky Arrhythmias where your A wave's huge. Can be huge, especially in a baby who's fairly sick with SVT or ventricular tachycardia. But that will allow you to measure AV interval as well. So you're seeing both atrial and ventricular contraction and the relationship, and being able to actually measure a mechanical interval. And again, there's normative data for those values. So it's not the easiest to do, but if you can get it, it is actually really helpful. And you'll see I have lots of examples. It's great for intervals, and it's great really for the assessment, I think, of all arrhythmias. So one other is the pulmonary artery and pulmonary vein Doppler that you can sample simultaneously. It takes advantage of the fact that the pulmonary veins and the pulmonary arteries sit really close to each other. The PAs are right above the pulmonary veins. So often if you can get pulmonary vein flow, and I should mention SVC is the same. The SVC can be hard to get. You get your SVC flow, and then you slightly move your transducer into the direction of your aortic flow. And you don't have to have it perfect to get the combination of SVC and aortic flow. The aortic flow, you just need a shadow of it, really. The same is true for pulmonary artery. You can actually get a really nice pulmonary vein Doppler profile and then slightly move your transducer towards the baby's head, and you'll pick up both, as is shown nicely here. This is forward flow in the pulmonary vein with reduction during atrial systole. So atrial systole presumably starts here. And then again, you get your S and your S and your D waves, where at the same time in the opposite direction, you have forward flow through the pulmonary arteries and a big systolic peak. So you can use that as the start of ventricular systole. So here's the A wave and the V wave, which is how you would then be able to assess. So it's relatively simple to do. It's less angle dependent than, say, SVC aortic Doppler, because you can get into one of the two wherever you are. But it can be difficult to measure intervals because it's hard sometimes to see exactly where the A wave starts. And I find it really limited in arrhythmia assessment, especially when it's irregular arrhythmias. We've used color TDI to published on it, as has the group in Toronto, but to look at assessment of arrhythmias. So the group in Toronto have actually demonstrated normative data for AV intervals. We've used it for ventricular arrhythmias, initially described by Azaria Ryan many, many years ago, but where you can really see your atrial, you basically have the color tissue Doppler image. You're placing your sample in either the ventricle or in the ventricle and the atria, which will come up as two different colors. And so you can play around even with your sample volume to get better signals. You do have to track through slowly. It's sampling at very high rates. Track through slowly to see when atrial systole is occurring and ventricular systole is occurring. But what we found is actually it provides much even cleaner data for your AV intervals and for really assessing the relationship between atrial systole and ventricular systole as seen here. So here's A and here's a V, and we've tracked through and found this to be the start, and this to be basically the start of your ventricular contraction, and you're actually getting a really nice signal there. This is just another one showing again your A wave is in your yellow, so I've got my sample on the atrium in yellow, and my V's are in green here, so I have my A and V, my A and V, and it gives you some sense of your relationship there. So relatively easy to do. Problem is it's not available on all machines, and it takes a bit of time to understand what you're doing. In fact, when we've gone a couple of months not using it, and you go back to it, it always is a little bit of relearning. It's not as easy as riding a bicycle. So fetal ectopy, atrial premature beats, ventricular premature beats, and junctional ectopic beats are what we're talking about. Premature atrial contractions, as we all know, are very common referral for irregular fetal heart rate, and in fact make up the vast majority of referrals for fetal arrhythmias. Often they're gone by the time you're seeing them, but most of the time, or many times, they're there. They usually present after 30 weeks, occasionally before that, and the ones before that I'd be very suspicious. They could be associated with SVT. And certainly most of them are benign, but occasionally they can be associated with supraventricular tachycardia, so you just need to be aware. They can be associated with structural heart disease, including lesions that are associated with atrial dilation, such as Ebstein's anomaly, tricuspid valve dysplasia, as well as tumors. And sometimes a lot of atrial ectopy may not be well tolerated by some of these conditions. If frequent, I would consider every 1 to 2 week physical profiles to make sure the baby's staying well and that there's not evidence of supraventricular tachycardia or cardiovascular compromise. Also, more recently, and really brought to our attention by Bettina Cuneo was the use of these handheld Doppler devices, which we've now purchased about 20 of, and we send out all the time. It's a really easy way to be surveying for problems, and in babies who have lots of ectopy, and we're worried about the possibility of tachyarrhythmias, we have the moms assessing the baby's heart rate every 3 times a day or so, while the baby has ectopy. And we've picked up SVT. We've also used end ventricular tachycardia. Other babies at risk for arrhythmias we've used to do surveillance, including babies with tumors, atrial dilation, ventricular aneurysms, Ebstein's anomaly, maternal autoantibodies, and left isomers. And we're looking for evolution of fetal bradycardia, and also monitoring treatment success. In fact, what we've done is we've been able to get the moms out after treating them for a couple of days on either sotalol or flecainide as an inpatient. We get them home and can actually do a lot of surveillance without them being in the hospital. We don't have to have them come back so frequently, and we've been able to adjust the medications as an outpatient, even with them being remotely monitoring from home several hours away. So premature atrial contractions, you see your inflow, biphasic inflow and outflow, outflow from the left ventricle. These are your atrial systolic events. And you can see that there's a long interval here, and with a premature atrial contraction, you get acute atrial contraction here with no E wave, and it's a short AA interval followed by a long AA as it resets the pacemaker of the heart. So there you go. So you long, and then a short one, and then a long. And this one's actually conducted with a much shorter V wave, and that's because there's less filling of the ventricle and as a consequence, less output that Catherine Reed reported many years ago in the 80s or so. Spc Aortic Doppler, here's your AV, your AV, your AV, and again, these are long AA intervals. And then this one's a short one. That's a short A to A interval, and that's because this is a premature atrial contraction with a ventricular contraction following right behind. Again, lower VTI of that Doppler because there's lower output as that ventricle has been less filled, has had less time to fill. Here's your A to A, that becomes long again, and then this baby remains in a normal atrial rhythm subsequent to that. This is just an example of M mode, but the baby has atrial bigeminy with conduction to the ventricles. So here's your A to V, that's a normal beat. This is coming in early. That's a PAC with a ventricular contraction thereafter, and then it resets. That's a long AA interval. This is the normal beat, A to V, and then again an early one. So you get the short, long, long kind of appearance, and that goes along with atrial bigeminy, and this is really pretty benign. Here's a PAC with block. You have normal AV, AV, AV by M mode, but there's this little A, and sometimes M modes can be hard to see it because those contractions may not be as robust, but you're getting an A and then nothing for the ventricular contraction, and then following up with another AV as a normal AV. So this is a blocked PAC. You also see it by inflow-outflow Doppler, where you get these biphasic inflows with a big A, V, and then this is actually an early, very early A, followed by a very long E, because there's a bit of resetting, and you end up with more filling, and then it actually has a normal AA interval there from the PAC. So this is a blocked PAC with no forward flow through the ventricular outflow following this premature contraction, but the next one often is a big VTI because the heart has had time to fill. And this is just an atrial bigeminy with AV block, where again you get the short, long, short A to A interval, and that is in keeping with atrial premature beats that are every other beat, or bigeminy, and this is benign. This baby doesn't have conduction during the PACs, and I'm going to show this one more time, but again, short, long, relax. This is just atrial premature beats in a bigeminal pattern. So premature ventricular contractions are a lot less common. They're a little bit more tricky to understand, and your first instinct is, oh, this is probably PACs, because most of the time it is, and you're gonna, if you guess, most of the time you're gonna be right. But in fact, sometimes there are PVCs, and sometimes there are important reasons that they have these. They're not readily distinguishable from premature junctional beats. That's one thing that's very important. By Doppler, you can't tell. And they can be associated with myocarditis, cardiomyopathy, or some myocardial disease, tumors, long QT tumors like fibromas and rhabdomyomas, long QT syndrome, and complete AV block with slow escape. This is an example of an Svc Ao Doppler I love. Here's the A to V. A to V, this is a normal AA interval. A to, it's a normal AA interval, but what you're seeing is a huge A wave. I love seeing this. It's a cannon A wave happening at the same time as an early ventricular contraction. So this is actually a PVC happening early, and it's coming right when the atria is contracting, and it's contracting, of course, against a closed AV valve. And as a consequence, you get a big A wave reversal. And then that is a normal A to A. So if you look, the AA intervals, which are the atrial or sinus beats, are normal intervals throughout. But what's happening is that early V is coming in at a time, again, the atrial contractions occurring, so you get that big A wave. So that's a really helpful finding to convince yourself these are PVCs. And then by M mode, you're seeing that this should be A's or sinus, A contraction, or just beating out. Look at the ventricles. So this is an A to V, boom, an early V when the A's are just doing their own thing, just continue on. So this is a premature ventricular contraction, ventricular contraction. This baby's having it every third beat, so ventricular trigeminy. And again, that's the one that we'd watch. I meant to show you, this is actually pulmonary vein Dopplers. I don't use it a lot, but this was kind of a nice one where you're seeing forward flow in the pulmonary vein, and you're not seeing much in the way of, you don't usually get an A wave reversal in a normal fetus. So you have forward pulmonary vein flow, normal systolic flow here, and what you're seeing is an early ventricular systole with a big A wave as in the pulmonary vein as a consequence, again, of the atrial contraction occurring against closed AV valve. So that's a nice example using the pulmonary artery, pulmonary vein Doppler simultaneous assessment of a PVC with a big cannon wave in the pulmonary vein. So Hacky Arrhythmias, you have two kinds, of course, supraventricular and ventricular. You also have, and in the supraventricular, I've included the junctional ectopic tachycardias, AV reentrant tachycardia with unidirectional or bidirectional pathways, permanent junctional ectopic tachycardia, which I'm not going to talk really about, ectopic atrial tachycardia. These are two really quite common tachyarrhythmias. Jet, really pretty rare, atrial flutter, and then ventricular tachyarrhythmias include isolated ventricular tachycardia associated with myocardial disease, and torsade. So the most important thing here is deciphering mechanisms, and this requires understanding the relationship between atrial and ventricular contractions, looking at atrial and ventricular rates, how the tachycardia starts up and breaks, what type of ectopic beats are present. That's really important when you have VA association in ventricular tachycardia, for instance. You need to see if there are PVCs in between when the baby's in an atrial rhythm, because if you don't, you're going to think this is going to be SVT, which is far more common than VT, and you may treat them wrongly or may miss the diagnosis. And then differentiating between VT and JET, as I mentioned, can be very difficult in the absence of fetal ECG or magnetocardiography. So AV reentrant tachycardia with an accessory pathway, which this baby actually has, and the heart's just jiggling away. It's the most common, most will say this is the most common cause of fetal tachycardia. I think EAT in our experience is nearly just as common, if not as common. It involves the presence of an accessory AV pathway, most of the time with reversed flow or with reversed conduction from the V to A with antegrade conduction through the AV node. So you get this reentrant circuit. It's associated most of the time with ventricular rates that range from 220 to 280, sometimes slower, sometimes certainly faster, and typically initiated with a PAC with sudden onset and offset, typically a constant rate, meaning constant beat to beat intervals, with usually 1-to-1 AV relationship. And this is typically a shorter VA interval than an AV interval. So that's one thing to recognize. It can be associated with Ebstein's anomaly, and as we know, WPW as an example is part of that disease. And 10% have WPW after birth. 90% have been shown to have concealed pathway. So this is just a little demonstration of that reentrant mechanism. By M-mode, you see really 1-to-1 relationship at a rate of 240, 250. Again, just seeing this alone, you can't completely exclude VTAC with dissociation, but the vast majority of these are going to be this kind of AVRT. I love the Svc Ao Doppler for this. You're really seeing your ventricular systole, and especially if the baby's been in it for a while, the atrial pressures are high, and you get a big A wave as well. So as well, that maybe just because, yeah, I think this is probably the primary thing. But here's your ventricular outflow or your aortic flow, and your A wave, and that V. Here we go. V to A is much shorter than your A, and really this should be here, A to the next V. So that V to A is a short relative to the A to V interval. This is another example where you have a V to A, the onset of the A, onset of the V to onset of the A, is much shorter than the onset of the A to the onset of the V. And so this is in keeping with a short VA tachycardia, short PR tachycardia. Most of the time is going to be this AVRT. And then we also will use our color TDI to give us a sense of this as well. You can immediately see a 1-to-1 relationship between the A's and the B's, and this is going to be in contrast to atrial flutter. And then we can actually do some measurements of your AV and VA intervals, and you can see that they're quite different, that the VA interval is much shorter. So that's an example. Sinus tachycardia, pretty relatively rare, actually, I would say, unlike what we see after birth. It's associated usually with the ventricular rates of 170 to 200, sometimes a little bit lower, especially later in gestation. This is considered an automatic focus, usually with gradual onset and offset, 1-to-1 AV conduction. This is a long VA tachycardia, unless there is AV block, which we've sometimes seen. It's associated with maternal hyperthyroid state or overtreated hypothyroid state. And it's not typically associated with fetal distress. This is unlike our postnatal response. This is not something that you see. Bradycardia is what you see, sinus bradycardia. Ectopic atrial tachycardia is one that we see quite a bit. It's associated with ventricular rates that usually range between 200 and 300. We've seen as high as 320, 330, and sometimes lower. And when they're lower, it's hard to distinguish between EAT and sinus tachycardia. It's an automatic, typically associated with an automatic focus with gradual onset and offset, but not 100% of the time, and variable rate. Sometimes we see premature atrial contractions in between as well. That's probably this little focus somewhere outside of the sinus node that's just wanting to fire. And then the baby will have 3 or 4 at a time and then go into it. Longer VA typically versus AV interval, although they may have, again, first degree AV block, which may lengthen the AV interval and make it a little harder to see which is longer, and sometimes they can be quite similar in interval lengths or durations, and may be seen in congenital heart disease, again, associated with atrial dilation and intracardiac tumors. So this is an example of a baby who had EAT at a rate of about 220. Your inflow-outflow Dopplers, you have the onset of the A to the onset of the V versus the onset of the V to the onset of the next A, and that AV interval shown here is shorter than the VA interval. We're shifted a little bit. This is the Spc Ao Doppler, which I actually really prefer using, and you're seeing the V to A be longer than the A to V. And like I said, the only time I've seen it where it's hard to really define that's a shorter AV interval is in the context where there's AV prolongation, so some first degree AV block, and then those AV and VA can be quite comparable. But I've only really seen that either in EAT or in treated AV-RT. So that may be something that can be helpful. So again, we'll use color TDI. Won't hang on this. I know that not everyone has this available to get a better sense that the AV interval is shorter than the V to A interval. And this is again in keeping with something along the lines of most likely EAT, but could also be sinus, again, if the rates are slower. Interestingly enough, I've used color TDI to give us a better sense of what's going on. We had this baby who was having rates that would be 160, 150, 160, 170, and then would have rates of 280, and then sometimes rates of 320, and it was really confusing. We were not sure what was going on, and we were thinking, oh, maybe the baby's having kind of AVRT, like an AVRT or a EAT, and then other times having flutter. So we weren't sure what was happening, and this actually one image helped us better. One tracing helped us understand that this baby, as the atrial rates were faster, and this was an EAT, you started getting AV block, and then as the rates slowed down, you started seeing one-to-one conduction. And so this was really helpful because it gave us one diagnosis in this baby rather than two different diagnoses, which people have sometimes described or thought was occurring. And in fact, this was just a baby that, as these atrial rates were ramping up in EAT, at higher rates, the baby wasn't conducting to the ventricles. At lower rates, the baby was conducting to the ventricles. So color TDI can be quite helpful. So atrial flutters, people will say is the second most common. Certainly that's what's been reported in our experience. If you look at EAT, AVRT, and atrial flutter, EAT and AVRT are more common, but a lot of reports don't differentiate those two, and they just are described as SVT. So some will say this is the second most common cause of fetal tachycardia. It's associated with atrial rates of 350 to 500, very, very high, much higher than often what you see after birth, and variable ventricular rates, most often 2-to-1 AV block is what we've seen. It's an atrial reentrant mechanism with shooting through the AV node to the ventricles, and often the AV node, fortunately, is a little sluggish, and as a consequence, you don't get one-to-one conduction, because I think these babies would not survive very long. This is a baby, obviously, with Ebstein's anomaly, who has a very dilated right atrium because of severe TR, and this baby's having atrial flutter. Usually this presents late in gestation. It's unusual to present prior to 30 weeks. And again, it can be, as shown in this case, can be associated with structural heart disease, especially those associated with dilated atria, and Ebstein's and tricuspid valve dysplasias are examples with, again, atrial enlargement. So this is an old M mode, but it really nicely demonstrates how fast the atria are going. The atria are going much faster than the ventricles, which you're seeing here every other atrial rate. So there's 2 atria to a ventricle, 2 atria to a ventricle. So this is going to be a baby that has 2-to-1 AV conduction with a very fast atrial rate. Love the Svc aortic Doppler profile, flow profiles that you're seeing. Here are the atria, and you can see that every other atrial beat is really getting conducted to the ventricle. So this is kind of really nicely showing 2-to-1 AV block in the context of atrial flutter with atrial rates that are very, very, very fast. Sometimes you see even 3-to-1 AV conduction or even greater block, greater degrees of block when the rates are very fast. So these are our atrial rates, very, very fast atrial rates, but the V's are happening every 3 beats, as you can see here by color TDI. So junctional ectopic tachycardia, very, very rare. I've only seen one myself. These are typically associated with rates of 200 to 280. Often in automatic focus, so you can have some ramping up and ramping down. There may be one-to-one VA conduction with really simultaneous, or even sometimes a little before your atrial systolic event is occurring, before the ventricular systolic event, or right at the ventricular systolic event. So they can have simultaneous VA waves. This may AV and RT may be in the differential. You can't differentiate this from VT, especially with association. They're rare in the fetus, and they may be associated with maternal autoantibodies. So if you're at all suspecting either JET or VT, be looking for maternal autoantibodies and be testing, because that may help guide you in treating and knowing what to do with the baby, as well as being able to counsel regarding future pregnancies. VT, much more rare. We've seen rates that have ranged from 180 to 280, most often with faster ventricular rates and VA dissociation, but I'll tell you, sometimes they can be associated, or they can be associated and dissociated in the same baby, which we've seen. Certainly, it's really helpful to see a PVC when it's an associated, when there's VA association. It's very, very helpful to find PVCs when the baby's in an atrial rhythm, because then you can be sure that this is a ventricular tachycardia and not an SVT. It can be isolated, be found in long QT, or be associated with cardiomyopathies, maternal autoantibodies, ventricular aneurysms, and tumors. This is just an example. This is a baby that had VT that was both associated and dissociated at times. And what you're seeing is the A waves are just beating out at their regular rates. Just like that. They're really consistent. But here you're seeing the V's. You have an AV, so this is normal. Oh, there's an early ventricular systole. Then an AV, and again, an early ventricular systole. So this baby was having ventricular bigeminy, in fact, right here, and then boom, went into VTAC. And you can see the ventricular contractions are happening much more at a much higher rate. Here's V, then the A's, then the atrial contractions. These are just marching out. They're normal, and the V's are going very, very fast. So this baby actually has ventricular atrial dissociation in the context of ventricular tachycardia. Probably a little more common than association, but that same baby, in fact, we found had periods of VA association shown by color TDI, which I thought was really quite interesting, and that was at fast rates of about 220. And then at times, you'll see when there's VA association, it's not unusual, especially if the A's are coming in, if the VA association is quite close, you'll get big A wave reversal at the time that you're getting your ventricular contractions. And so you'll see this big A wave reversal representing cannon waves in the ductus venosus or in the IVC and hepatic veins. That can be very helpful. We've had rare times in which they've actually more represented accelerated ventricular rhythms. And I thought this was kind of interesting, because this was an Spc Ao Doppler in a baby with an accelerated ventricular rhythm. Baby was not unwell. It was a baby that had a absent pulmonary valve syndrome, but wasn't unwell, but was having these periods where the SVC had, here's your A wave, A wave, A wave, and the ventricles were happening just a little before the A wave. But they were slow enough that the baby seemed to be tolerating it well and didn't get into any sort of big trouble. So this was one where the ventricular rates are a little bit faster. Not really quite the ventricular tachycardia that we would be more worried about. So fetal bradycardias, quickly, this includes sinus or atrial bradycardia, long QT, atrial premature beats with AV block I had already mentioned, is certainly a reason for, probably one of the most common reasons for fetal bradycardia that you just can't get excited about, and then different degrees of atrial ventricular block. Sinus bradycardia, really the most common cause of fetal bradycardia. Typically, there's one-to-one AV conduction with gradual onset and offset. Most of us have seen that with just pushing the transducer, but sometimes the baby's heart rates go lower. And these are typically heart rates of less than 120, but there's normative data that you should really be using, especially for the long QT cause of this. And it's looking for rates that are low in the second and third trimester. So if constant, it's more often associated with general unwellness of the fetus. We've also seen this in aneuploidy, especially early in gestation. But it can be seen in long QT, maternal autoantibodies, anti-Ro, anti-La, fetal heart disease, and left atrial isomerism. So be looking for this in babies that have sinus bradycardia. And this is just an example where it was actually sinus bradycardia. In this baby, where mom herself had lupus, she had autoantibodies, high Ro and La antibody titers, and you're seeing a nice long E and an A, V. Nice long E, A, and V. This baby has one-to-one relationship, but at rates that were about 80, 90. This baby clearly had sinus bradycardia. We confirmed this as well with our A and our Vs by colored tissue Doppler. And this was associated with SSA and SSB antibodies. This baby also had LV and RV echogenicity. So this was one manifestation of maternal autoantibodies. Another one, this is another baby who had persistent unexplained sinus, what looked like atrial bradycardia at rates of 20, both at 24 weeks. We showed it again at 34 weeks, but there's a one-to-one AV relationship. So this is a low atrial rhythm, and this baby's heart rates were 90 to 110, which is definitely not normal. And we showed that the AV intervals, in fact, were completely normal on all of these beats. So there wasn't evidence of real AV conduction disease. We said this is sinus bradycardia. In fact, this baby had long QT and was a very helpful diagnosis because there were other family members with long QT as well. So prenatal features you need to know about for long QT or persistent unexplained sinus bradycardia with heart rates of less than the third centile, nicely shown in this study by Bettina and Jeanette and others in their center years ago. And this is actually, they looked at pregnancies at risk for fetal long QT because of family history and found that those that were affected in the triangles had clearly sinus bradycardia in the vast majority of them. Those that weren't affected were less likely to have sinus bradycardia. So an important study and important finding. Also unexplained 2-to-1 AV block with normal AV intervals on the conducted beats. That's a very important finding associated with long QT. And then, of course, intermittent ventricular tachycardia in keeping with a torsade picture. Most of these have been actually quite sick fetuses. So in evaluating for sinus bradycardia, we always will assess the family history for evidence of long QT. We also do 12 leads in the parents. And if we can get a hold of colleagues who do fetal magnetocardiography or ECG, we would do that as well to make that diagnosis. But have picked up several since that paper published in Circ in 2013. This one I already showed you of atrial bigeminy with AV block. These are sudden onset and offset of bradycardia. The vast majority of these after 30 weeks are not going to be something terrible. The vast majority of these are going to represent just PACs with atrial bigeminy and block during PAC. And these ones we should really relax. The only issue is that it can make monitoring of the baby during labor quite difficult, and sometimes for many programs would end up resulting in a need for cesarean section. First degree AV block, there's usually a normal heart rate. So this is not a baby that you necessarily will be identifying as a consequence of Doppler assessment by the OB suggesting arrhythmia. But what we're doing is looking in babies who are at risk for AV block. This is a baby who developed in the third trimester with congenitally corrected transposition, or LTGA. And what you're seeing with this Svc Ao Doppler is the A wave happening way before the V, but there's a consistent relationship there. So in this baby, very long AV interval, usually greater than the third centile for normal AV event intervals, are what we're looking for. They're not the ones that are 140, 150, 160, just on the borderline. They're largely ones that are very long. And they're ones that we would be looking for in those with L transposition, congenitally corrected transposition in double inlet left ventricle as well, left isomerism, and then maternal autoantibodies. So those are the babies at risk. Next are our second degree AV block, and Mobitz 1 is an example where you'd get just skip beats. You also see that, of course, in Mobitz 2. This is just an example in the same baby who at times had these long AV intervals, but the baby would then drop a beat So we're like, oh, this is Mobitz type 2. But in fact, if you look at the next one, it's a shorter AV interval, then a longer AV interval, and then the baby was dropping a beat. This would actually be so short AV, longer AV, and then a drop beat would be in keeping with Wenckebach, which we've seen even as early as 14 weeks. And not necessarily one that would progress. So that's, again, one that we would be looking for in those at risk for AV conduction disease. This is just an interesting case. This is a baby whose mom had Sjogren's and high antibody titers, had completely normal AV intervals, completely normal heart at 18 weeks, but at 20 weeks had tricuspid insufficiency. And we'll show you another image that's pretty interesting. But TR, systolic function was good, completely normal conduction, AV interval was completely normal at this stage, good function, good flows, everything looked good, but there was a little bit of brightness of the RV papillary muscle. So we brought her back a few days later. And in fact, this is what the heart started to look like. You get some echogenicity of the AV areas as well as the chordae. And this baby had this RV inflow pattern within just a few days. Very abnormal inflow pattern, short duration, no E wave, certainly suggestive of abnormal diastolic function. The AV interval here was starting to get much more prolonged. Same baby, 180, 190, and the baby was having Wenckebach. So we were actually quite worried this was a mom who got treated with IVIG and steroids, and Joanna's going to be talking about this. Dr. Dengel is going to be talking about this shortly. This baby went on to have normalization of everything within about 3-4 weeks, and after birth was great until the age of 3 when she started developing second-degree AV block. Hasn't yet been paced at the age of 6. So interesting. So Mobitz type 2 is where there's more consistent dropped beats as a consequence of AV conduction disease. This is an example of LV inflow outflow, where the inflow is short, it's just a little A wave, and then the V, and then A wave and nothing, A wave, V, A wave, nothing. This baby also had some myocardial disease, which we think explained the uniphasic ventricular inflow. And then Spc aortic Doppler, your AV is here, and then you have an A followed by nothing. The AV is here, so you have a consistent AV interval on the conducted beats, and then you drop. So what you want to do, though, is make sure that you run at slow speeds over a long period of time to make sure that it's not just there's not eventual AV dysynchrony, and then it would be, in fact, a baby who doesn't have a second degree, but rather third degree. So I always run kind of a long run of many beats like this to see that for sure it stays AV every other beat, that there's definitely synchrony. So the atrial rates in this context, where there's 2-to-1 AV block, of course, are going to be twice the ventricular rates. I always also, on the conducted beats, will again measure the AV intervals to have some sense of AV conduction generally, which can be helpful in thinking about the possibility of long QT and that differential. And then, of course, complete heart block is lack of AV synchrony. Your A's are just marching out, and you really have to sometimes march them for a long time, again, with lots and lots of beats with slow rates of sampling. And then you're seeing that there's really eventually no relationship between the A's and the V's are at much lower rates, often between 45 and 30 and 120, 45 to 75 is more typical, but sometimes we've seen them down to in the 30s, which really worries us, of course. Atrial rates are usually normal, except for in left atrial isomerism, so that's one thing, and sometimes in autoimmune-mediated disease, you can have sinus bradycardia, as I've shown you before. The majority of them have either structural heart disease or maternal autoantibodies. Then,
could you say that again?
And 5% and about 5% have isolated AV block without maternal antibodies. And always think about NKX 2.5 or something else that might be genetic. And we'll check with the family that there's no family history associated with such things. So this is just an Spc Ao Doppler, where you really can see that the A's have no relationship, sometimes running into the V's and sometimes not. And this can be really helpful in making a definitive diagnosis of complete AV block. Especially in left isomerisms. I don't know why, but often the atrial rates are just close to twice the ventricular rates in those, and it can be sometimes hard to be sure that it's not 2-to-1, but really running a long strip, you can be more convinced that there's no relationship. And then we'll also do this and confirm by color TDI, which the A's are here and they're just doing their own thing, and the V's shown in yellow are doing really their own thing, and there's no relationship. Just of note, the structural lesions, 70 to 80%, will be left atrial isomerisms or polysplenia with 2 to 1. These are usually more associated with complex structural heart disease. Most with left isomerism also have this non-compaction cardiomyopathy, and their outcomes are very, very poor. And it's, again, not unusual to have atrial bradycardia in this particular disease to keep in mind, and we'll watch. We have some that have just sinus bradycardia as well. 10 to 15% represent congenitally corrected transpositions, and another 10 to 15% or so other lesions, usually with left ventricular looping, such as single ventricles. And these are ones that you will often see quite early. This is a baby with left isomerism with very complex congenital heart disease and dextrocardia, diagnosed at 13 weeks. And this baby was already in complete, this baby had 2 to 1 AV block, actually. So here's 2 beats to 1, 2 atrial contractions, and 1 ventricular contraction. So this baby, you can see this kind of abnormal AV block presentation quite early in this disease. I think it's actually really interesting just to note that fetal. Yep. I'm almost done. I just have a couple more slides. So fetal magnetocardiography has taught us a lot about this disease, where they have very monotonous and less reactive ventricular rates. They're less responsive to beta sympathomimetics. And the observations are in keeping with a malformed conduction system. They're also at much higher risk of loss and evolution of high drops. And this is a rare autoimmune mediated AV block where you get really, really slow rates shown here. This is a disease that Joanna is going to discuss, so I won't go through this. Just of note, though, these moms, the vast majority of them are clinically asymptomatic, or you really have to look for autoimmune disease. And that's 70 to 80%. Absolute antibody titers have been related to the disease. And the mothers with hypothyroid states, whether or not they have another diagnosis of autoimmune condition, have a 9-fold increased risk of fetal AV block. And there's, of course, a much higher risk if you've already had one affected baby. So this is a diagnosis that we need to be really very aware of. There's also some data that would suggest they have more reactivity, these babies, especially when they have ventricular rates of greater than 56 based on fetal magnetocardiography, but they can also be associated with ventricular ectopic beats, jet, ventricular tachycardia, and rare atrial tachycardia. So be aware of this with this disease. So this is when the ventricular rates are higher, you can see more variability. When the ventricular rates are much lower, those babies have much less variability. They're much higher risk for getting into trouble and more likely to need pacing. They also are associated with this sort of myocardial disease. Again, Joanna should be touching base on this finding. So in summary, the diagnosis of fetal arrhythmias is possible with definition of the actual mechanism in most, but tools we use largely infer the mechanism from mechanical and flow-related events. It requires an understanding of the unique features of a given arrhythmia, including its onset, rates, and AV relationship. And the most common arrhythmia that we see is premature atrial contractions. The most common tachyarrhythmia, SBT, most often associated with an associated pathway, and the most common of fetal bradycardia is in fact sinus bradycardia. So with that, thank you very much for your attention, and I'll
thank you, Lisa. Beautiful talk and really very rich in information. And perhaps we have one or two. We're over time, but maybe you can ask one or two questions, because the other speakers will also go into the treatment and the tips and tricks. Now, the handheld Doppler that you talked about for the maternal, that the mothers can take home, I heard that you can get it from Amazon. How did it help you? Give me examples, Lisa. How did it help you? In which cases? And how did it help in management and counseling?
Right. So this is, as I mentioned, we've had babies that have had lots of PACs. And when they have lots of PACs, you have to be a little bit suspicious. They might be ones who are in and out of EAT. When we're only sampling for 20, 30 minutes in our exams, you might miss something. So we send the moms home, and as soon as the baby starts having tachyarrhythmia, mom's on the phone with us. We bring her in, we start treatment, confirm the diagnosis, start treatment. If we can't confirm the diagnosis, at times we have waited. And then once they start going into something more regularly, then we've looked, or After delivery, we then follow up with the baby doing usually a Holter and have picked up SVT there. I've also had cases of PVCs that have ended up with ventricular tachycardia that were, that had been missed had we not done surveillance, and block as well. So we've had moms who live hours away. We send them home. We don't do as frequent. We get our obstetrical colleagues to do biophysical profiles closer to home, and then we actually have the moms doing the surveillance, and then they call us if the baby's in SVT. We change the medication. So for Sotalol as an example, if we have mom on Sotalol and it's on twice a day, we'll go to 3 times a day, get her to get an EKG locally. So really we've ended up reducing the amount of times that these moms have to come see us, which is great. Same with we're also using it quite a bit for the autoantibody positive moms and the left atrial isomerisms as an example, looking for any evidence of drop beats or AV, actual frank AV block, to be able to start treatment, which we would potentially offer, whether that's for autoimmune disease, the anti-inflammatory kind of approach, or even use of beta sympathomimetics.
So simply you tell the mother, you give them numbers. If the number goes above this, call us back, and so on, right? For the Hacky Arrhythmias, for the Bradyarrythmias. So giving them numbers and giving them access to call you back. And this really did make a difference in the counseling. That's very, very nice. Could we, there's one beautiful slide that you showed where you can diagnose complete AV block with the pulmonary veins, Doppler?
No, so none of the blocks were with pulmonary artery Doppler. I think that's one of the ones that's quite difficult because you get a lot of erratic flow in the pulmonary veins that are really hard to define, unless it's say a 2-to-1 where there's some regular element to it. I can't use the pulmonary artery Doppler. You'd only use that. There was a nice example of a PVC where you had a big cannon wave in the pulmonary veins, but I tend not personally to use pulmonary vein Doppler on a regular basis.
You just showed one slide, but maybe I got it wrong with the pulmonary veins, because I find it very not easy to diagnose sort of blocks with pulmonary vein Dopplers. But the message here that is clearly in your talk is that choose the Doppler as much as you can and try and get away from the M mode, or you say, okay, we do both?
So I usually have M mode as my quick and dirty, this is the diagnosis, and then I kind of fine tune it. So I like AV, I use it for, and my sonographers and fellows often find it really easy to do first, but then we actually fine tune, and my next go-to is an Spc Ao Doppler. So I get everyone to learn to do Spc Ao Doppler, because I think in terms of really fine tuning mechanisms, that's probably the best.
But with the M mode, usually you don't see the, what is the technical advice with the M mode? Because you don't see the edges very clearly of the ventricles sometimes. And you need to play with the filter, or do you play with or you use a high frequency probes? What is the advice to get a good M mode?
I mean, I make sure that you're not looking at a tiny little image with a massive sample, right? So you want to get your sample small enough. You don't want a baby who's moving. That's really problematic. You like them when they're really calm. And then usually go through the AV groove, catching the right atrium and usually the right ventricle, but you can also, as I showed you, go through the left ventricle. Again, for me, it's kind of the quick and dirty, this is a basic diagnosis, and then I go for gold by using the Doppler to further fine tune and confirm a diagnosis. And for SVT, we consistently try to get our AV and VA intervals. And I would
Some
say
people
probably
said forget about M mode. Some would say forget about M mode and go for Dopplers. But yeah, I can see Joanna saying no.
Sometimes it's really hard to get the Dopplers perfectly, and especially Spc Ao Doppler, which I really, like I said, love. Sometimes they're a little bit more of a challenge, and until you've kind of can more consistently do it, I would say I probably can get an Spc Ao Doppler 95% of the time. I've been doing it for years, right? But if you can't, at least you can make a basic diagnosis by M mode. So I think for the guys who are starting, for some of the more challenging babies, an M mode is a great way to start. And then ultimately, learning the technique of Spc Ao Doppler, and you can use that for the vast majority of babies to really fine tune your diagnosis.
And do you agree to that? What would I mean, you're the expert. You're a electrophysiologist. You're the hero for magnetography. We didn't come to you yet, but what do you think?
I agree with Lisa entirely. I think there is definitely a role for M mode, especially with certain types of arrhythmias like black atrial bigeminy. and ventricular tachycardia, where you can easily see the atrial rhythm being regular and dissociated. So I think that's when I tend to use it. I think it's a mainstay. I don't think it should disappear.
Okay. Joanna, I think you agree to that.
I absolutely agree, especially that we quite often have to rely on the primary diagnosis of obstetricians, and for them Doppler in arrhythmias is completely, they are lost completely. So I think that it's easier for them to count atrial and ventricular rhythm than to see the Doppler and what's what. So I think that we should teach them M mode and just to understand why they should count the atrial rhythm and ventricular rhythm. That's it.
What sort of probe do you use to get a good M mode? Do you use high frequency or just the usual ones?
I use both. I mean, I certainly the better M mode is using the sector cardiac probe than convex probe, but it depends. Actually, it depends on the mother and on the fetus and on the image we can obtain.
Janet?
With the color M mode, which is helpful as well.
Yeah, it
Jeanette?
just takes a little time to learn the technique, right? And
Yeah.
play around with it. But-
Yeah.
I don't have anything to add to that. I think they've both answered it adequately. I'm trained as an electrophysiologist and do echo on the side, so I think I'm probably the least. If you can see the heart and you can see it well, you can usually get a good M mode.
Right.
That's true.
Very, very good. Now, tissue Doppler, Lisa, you've shown beautiful images for tissue Doppler. I think the trick in tissue Doppler is is it putting the sign one in the atrium and one in the ventricle, or how to get because you can always create things with tissue Doppler. So what is the advice to acquire a beautiful image of arrhythmias? I think you have to have a 4-chamber and the apex has to be down, and then you have to go with the frequent. There are lots of limitations that you can.
Yeah, so it's less. So the approach that we have is less angle dependent because we're using color TDI and doing offline analysis, and you can play around with your sample volume and the location of that sample in the atria and the ventricle to start creating this relationship and overlaying your ventricular and atrial contractions. The hardest part is that you really have to take time. And I mean, the EAT one was like a shock. We had about six several beat clips that we had captured, but we were so confused about this baby's rhythm. It takes time though, then to play around with it like you're in the EP lab. Honestly, it takes time. So yeah, it's a labor of love. And so for the really unusual ones, I find it really helpful. For the regular ones, do you need it every day? No, probably not. For the regular ones, M mode and your Doppler are good. But it can be really helpful for some of the unusual arrhythmias, and it's playing around with those sample volumes. The paper that we put out in JACE a couple years back with Sylvia Alvarez, as the first author, really kind of talks about trying to optimize your signals to give you that, but you have to kind of scroll through to identify atrial contraction, beginning of ventricular contraction. You have to play with it a little bit to get it right, but it can be very rewarding. Actually.
You put it anywhere is the lateral wall of the atrium, lateral wall of the ventricle, or just anywhere in the atrium, anywhere in the ventricles? What is your advice?
The best, if you want to get really good signals, probably being as parallel to the motion of the heart is great, but you don't 100% have to. You just have to get good motion of some sort. So you're seeing when the wall is moving, right? You're not looking for the absolute velocity. You're looking for when the wall is moving. So that's the key.
Relationships as well is very important.
Yeah.
Thank you so much. We can go back to more questions, but we have to move. And our next speaker is Joanna Dangle. Joanna has been with us for the third time, and I get to know her when she was the head of the fetal cardiology group at the APC, done a beautiful job. And she's a professor in Warsaw, and just say I would like to a physician at the Medical Academy of Warsaw, completed pediatrics and pediatric cardiology training in the biggest hospital in Poland, Warsaw Memorial Hospital for Children Health Center. And also she went to Guy's in London, Liverpool Children. She went to the US. She's been the head for the department for quite a long time. And she has lots of publications since 2017, head of the Department of Prenatal Cardiology and Congenital Anomalies in the Center of Postgraduate Medical Education in Warsaw. We're very, very grateful to have you talking about fetal arrhythmias. Please, Joanna.
Thank you for the invitation. And shall I share my screen? Yes?
Please do.
Okay, you can see this, yes?
Yes.
Does it work? Okay.
But put it on the presentation mode, please,
Yeah.
Joanna.
I know, yeah. I'm especially happy that I'm here because I remember our beautiful time with Lisa, which we spent more than 20 years ago in Minneapolis in a fantastic seminar. So I think that both of us has very nice memories from that time. So my topic, which I got from the organizers, and thank you very much that you thought about me and that you invited me once more to Congenital Heart Academy, was Fetal Bradyarrythmia, to treat or not to treat. I was thinking what to talk, and I think that the topic is not easy, but I will try my best, mainly basing on the own experience and the reports. I have no disclosures. Just to show you how busy we are, I run the Fetal Cardiac Center in Warsaw. Of course, we have referrals from the whole Poland, and every year we have more than 4,000 fetal echocardiography exams, the full fetal echocardiography, and more than half of them are abnormal. And comparing to the congenital heart defects, fetal arrhythmia is around 100 every year. So it's not so common. So I think it's so important that we share our experience and do the multi-center study, because on the other way, we can't really understand, especially the best way for treatment of our patients. The other thing is that we really have the possibility to evaluate and fetal arrhythmia and congenital heart defect, because always the termination rate of pregnancy concerning the isolated cardiac defects were very low, less than 10%. But let's start for the definition. What is the fetal? What is the fetal arrhythmia? Of course, the fetal heart rate is the first sign of the fetal living. And we can see it as early in 5-6 weeks of gestation. That this is the courtesy of my colleague Agata Włoch and the first beating embryo. At that time, it is not possible to see the Doppler trace, which is quite important. And we must know what heart rate, what the embryo heart rate is normal, because we know that the low heart rate in the very early first trimester of pregnancy is a very bad sign, and at that time it is not possible of treatment in any case. To talk about the fetal bradycardia, it's fetal bradycardia is one of the most stressful signs for obstetricians. So it is very important to distinguish obstetrical from cardiac reasons of bradycardia, because if placental function is abnormal, this can be life-threatening for the situation, and quick delivery is very likely. In contrary to the situation when we have the cardiac reason, because we need then the full diagnosis, as the quick delivery in cardiac bradycardia will be a mistake. And as we all know, CTG is a gold standard in obstetrics. I'm very happy that Lisa didn't touch even CTG, but for obstetricians still it's important, and we can't rely on this for diagnosis of fetal arrhythmia. So we have to educate our colleagues obstetricians why this is not good and how to interpret the CTG in cases of fetal arrhythmia. One of my fellow did his doctor's thesis basing on the intrapartum CTG in fetuses in whom we knew that they had arrhythmia or congenital heart defects. And you can see abnormal CTG, and none of them were life-threatening for the fetus, because their cause was cardiac, not the placental insufficiency. And one of the I think, very important CTG when the fetus had the premature atrial contractions, and the CTG is completely ruined. So we know that it is useless in fetal arrhythmia, and we shouldn't treat the fetuses, especially delivering the baby earlier, basing on that. So what is the normal fetal heart rate? As we know, figure definition is that the fetal heart rate is between 120 or even 120 to 160 or even 110 to 150. And I compare to work in which in one there were almost 50,000 women in the intrapart close to delivery, basing on CTG. And as you can see, majority of them had this their fetal heart rate between 120 and 160. In contrary, when we see 110 and 150 and compare them to the cardiac data, these were fetuses from mother with long QT syndrome, but they were healthy fetuses. We can see that it's 110 and even 120 from our cardiologist point of view is always low. So for me, always, when I see the fetus in mid-trimester and with 120 heart rate, I always had the red lamp, oh, something probably is wrong with this fetus. However, for obstetricians, it is normal. Then we must remember about the fetal physiological bradycardia. It's 21 weeks of gestation. Of course, it is entirely normal. The heart can stop completely. It doesn't need any further investigations, and of course, it doesn't need any treatment. Then cardiovascular profile score, which will be abnormal in majority of fetal arrhythmia, because due to fetal arrhythmia and abnormal atrial pressure, we will have the abnormal ductus venosus and and umbilical vein tracing. We can have the sometimes height drops or heart size. But for me, it is very useful when we are treating the fetus and we know that it's improving or deteriorating. So the first step, and Lisa already told this, for the evaluation of fetal bradycardia is the abdominal cavity. And of course, all of you know how to evaluate the stomach on the left, the aorta on the left, and the inferior vena cava on the right side. And the spleen should be visible. And in this situation, we can see, this is right, this is left, and we can see the inferior vena cava on the right, but this is the azygos vein posteriorly on the left of the aorta. So this is really the very, we know that this is the interruption of the inferior vena cava and continuation through the azygos vein. The very probable diagnosis, especially if it's not the isolated sign, is left atrial isomerism, in which we have the sinus node absent, and in the fetuses we can have heart rate around 100 per minute, as the fetuses are had the atrial rhythm, not sinus rhythm. They didn't have fetal circulatory insufficiency. They had completely normal peripheral flow, so they didn't need any treatment. And as an example, this is 14 weeks gestation, and the fetus was referred to us as early because the fetal heart rate was 133, which of course is bradycardia in that stage of pregnancy. Additionally, it's not the best picture, but I will show the better one. The stomach was on the right and the apex was on the left. And additionally, when we see clearly here, we can see two vessels behind the left atrium in front of the stomach. So we can suspect that it is enlarged azygos vein, and then we confirm this later in pregnancy. The heart had normal anatomy. It was the interruption with IVC with mild bradycardia in the fetus without any other problems. The bradycardia was around 100, 115, 116 throughout the pregnancy. It was the CTG which was confirmed during intrapartum CTG. Everyone knew that it can be around 100, so nobody was stressed because of this. And the baby was born with atrial rhythm, with no further symptoms. So of course, no treatment was necessary, or it could be pregnancy or later on. But I remember the first case, it was many, many years ago, in which the fetus was in the heart rate of 100. And I thought, you know, it will not be faster because it can't be, but everybody were afraid to discharge this lady from the hospital. So she spent in the hospital, I think, 3 or 4 months. But the baby, of course, had the very mild left atrial isomerism with right atrial rhythm. And then the other signs of bradycardia, as I told, is 34 weeks of gestation, double outlet with hypoplastic left ventricle. And 1 week before, the lady had the fetal echocardiography in which the premature atrial contractions were seen. And I told her, look, it is possible that the CTG in your baby will be ruined. For obstetrical reasons, she had to be admitted to the hospital. And we can see that the CTG is abnormal, but it is very typical for premature atrial contractions, which were confirmed by the peripheral flow, which had completely normal PI on the 35 weeks of gestation and such congenital heart defect. And CTG was very typical for arrhythmia. So, of course, arrhythmia shouldn't be treated, and the baby shouldn't be delivered in 35 weeks of gestation due to this kind of arrhythmia. So, no treatment. And the other thing, when we see the premature atrial contraction, we should look carefully on the foramen valve flap, because the foramen valve aneurysm can stimulate premature atrial contraction, and it can be the reason that they disappeared just after the delivery. And then it was the case was referred to us because of abnormal peripheral flow. As you see, from time to time we see the reverse flow in the ductus venosus and typical bigamy. And here I think that M mode is very useful because we can see the atrial bigamy with blocked atrial contractions. And this MCA is fetal heart rate 83, so this is not complete block. And of course, as Lisa already said, we can sleep carefully. It didn't need any treatment. Of course, we checked those ladies, but we do not anything. We do not put them on any drugs because it's just very mild part of bradycardia. So if the fetal heart is normal, if the appearance of valve aneurysm is normal, if the amniotic fluid is normal and PI in the umbilical artery and MCA normal and normal biometry, then the most likely cause of fetal bradycardia are blocked atrial contractions. So the obstetrician shouldn't make the final decisions and deliver the baby just based on this diagnosis, but make the really full diagnosis of the cause of fetal bradycardia. And now we are going to complete heart block, and I'm not going to talk about all of them because with the heart block with congenital heart defect, there is no any treatment. There were some experiments with fetal pacemaker, but personally I do not believe in this, because if there is already the fetal heart failure, from my experience, I do not have any survivors. If it's fetal heart block without fetal heart failure, it depends on the kind of underlying heart defects. So I will focus on complete AV block, because this is the kind of bradycardia in which probably or might be we can do something, and especially that there is the most common AV block in fetuses. What is the incidence? According to Dr. Riege's data, the incidence is 1 in 10,000, so a bit more than it was thought before of pregnancies, not live birth. So in my country, it should be more than 30 cases per year, but I don't think that we have so many cases. I think that the reason for this is that, unfortunately, still quite commonly those fetuses are born prematurely, and then the chance for surviving is much lower. The main cause, as we know, this is rare right antibody antibody. So these are mother with different connective tissue disorders, but we know that the fetal AV block can be the first sign of mother's connective tissue disorders. The cause of this is fetal exposure to a high amount of material antibodies after 15 weeks of gestation. So after the time when a placenta is starting to work properly, usually the block appeared between 18 and 24 weeks of gestation. It's very important that the fetal heart rate in the first trimester is usually entirely normal. It's even in majority of cases not slight bradycardia. So what do we do with those mothers? In my unit, we monitor those if the mother know that she had anterior antibodies. She is monitored every week between 15 and 24 weeks of gestation. After 24, between 19 and 24, it's every month. After 24, it's every month, and after 30 weeks, it depends on the fetal heart rate and AV time interval. If the AV time is more than 150 milliseconds, or the fetal heart rate is slow, then it's a question mark what to do. Lisa already showed how to diagnose the fetal heart rhythm. The important part of the monitoring is the fetal heart rhythm and measuring of the AV time interval, which is from the beginning of the A wave in mitral valve inflow and the beginning and the opening of the aortic valve. According to our data, in normal fetuses, it's between 100 and 150 milliseconds. Median was 123. And it should be measured in patients, especially with positive around fetal bradycardia. But in my unit, we measured this in all fetuses. So I think that we will have more normal values to be published and to rely on. Just one example, because if we should or can treat something, it is quite old study as well, because I think it's just one of the few fetuses which had the first degree AV block. It started in mid-trimester with the fetal heart rate 120 per 125. It was about 20 years ago. So obstetrician said, no, you are joking. It's not possible that this fetal bradycardia. I said, look, I am worried about this baby. So please, it has to be delivered in our referral hospital. So of course they agreed. And during the whole pregnancy, the AV conduction time was prolonged in pulse Doppler and in tissue Doppler. In tissue Doppler, AV time is always a bit longer than in pulse Doppler. There were no signs of heart failure throughout the pregnancy. They were fetal heart rate around 120 minutes throughout the pregnancy. And the baby boy was born with Apgar 10 points, with ECG AV block first degree, and with congenital hypothyroidism. So the question appeared, could we do something more during pregnancy? Should we treat something? Should we check something in pregnancy? We didn't do anything, but always at the moment we look at the thyroid and have in our mind if it can be something with the fetal thyroid if you have the bradycardia, but we have much more knowledge at the moment. And now we are going to the women who had the anti-RA antibodies. So this is the normal monitoring. 16 weeks, 17 weeks, and 18 weeks. Sorry. And as you can see, the AV time is always normal. It's 114, 110, 116. But the fetal heart rate in 16, 17, and 18 weeks is always a bit below or just above the lower normal limits, basing on our cardiac normals. So, okay, we were monitoring this lady. In 20 weeks, the fetal heart rate was 138 and AV time on 120, so it was okay. It was 20 weeks and 3 or 4 days, and due to some mother's reason, the next examination was in 22 weeks. And it was to the examination, which my fellow was a bit frightened because he saw quite hyperechogenic aneurysm of both AV valves and insufficiency of both AV valves, which certainly was not present in the previous examination. And in 22 weeks, the AV valve interval was 250 milliseconds, and fetal heart rate was already 120. It was 6 p.m. in the afternoon, so we decided that we will give the mother the high dose of oral dexamethasone. So she got 8 milligrams immediately after that, and 6 hours later. And at 8 o'clock in the morning, she was on the next examination. And unfortunately, it was complete heart block next time. We tried to put her on dexamethasone for higher dose, but nothing happened, and the baby needed the pacemaker. She was born at the heart rate of about 60. So we are learning, and next time they are data which I got from my colleague from the other town, Wrocław, Małgosia Raś. I think this is a very, very interesting case. I didn't remember this, that she diagnosed the complete heart block in a completely healthy woman. Nobody knew anything about hers. And she came for fetal heart examination because the fetal heart rate was a bit slower 2 days earlier. And she had the documentation that the fetal heart rate was 137. It was Monday, and on Wednesday, it was complete heart block with the fetal heart ventricular rate 68. So I think that amount is very helpful for this. So the decision was that the mother should be admitted to the hospital. Of course, the test for antibodies was done, but it is not so quick examination. So after the consultation, we agreed that we should try to help this baby. So we put the mother on intravenous dexamethasone, and then a few days later, when we organized everything, the mother received the immunoglobulins 1 gram per kilogram. And what was the effect? The complete heart block disappeared, and a first degree AV block was in the next examination, which I will show you. And since about 25 weeks, the AV interval was 150, and it was 150 until the end of pregnancy and in the baby. And this is 22 weeks of gestation after immunoglobulin treatment. As you can see, hyperechogenic annulus of both AV valves. Not completely normal flow across the AV, mitral and aortic valve. So it was really quite impossible to measure AV time. So I used the Doppler, pulse Doppler tissue imaging, and in pulse Doppler tissue, the AV time interval was evidently prolonged, 264. So it was probably about 200 milliseconds comparing to the pulse Doppler, with fetal heart rate about 136, so it was not bad. The baby was then under the care of Małgosia Raś, and everything was normal until delivery. The baby was born with first-degree AV block, and at the moment, the AV time prolonged from 120 to 250, as she told me. So the baby was put on steroids at the moment. We are looking what's going on. So I think that in this situation, the immunoglobulin and dexamethasone really work. So basing on this, sometimes later we had a patient who appeared in our unit in 20 weeks of gestation with fetal heart rhythm 103, and we knew that the lady had, the mother had Sjogren's syndrome. It was normal umbilical, MCA and ductus venosus flow, and AV time was not prolonged. However, it was bradycardia. So we think, okay, mother had very high titer of antibodies. So we decided to give her dexamethasone intravenously and immunoglobulins, and the effect was spectacular, because 1 week later, the fetal heart rate was 156, completely normal AV time interval, and completely normal peripheral flow. So we were very happy. The mother was on small dose of steroids, which we just lower and discontinued. And 1 week later, the obstetricians from the other part of Poland called me and said, is it possible to see this lady once more, because she is on complete heart block? So 1 week was completely enough to have complete heart block, which we were sure that we could stop giving the drugs. So we repeated, of course, the treatment with dexamethasone, with immunoglobulins. We didn't have any effect. However, the mother, due to the fetus, didn't need any beta mimetics, because the fetal heart rate was about 55, 60. And there were no any signs of the fetal heart failure apart from these hyperechogenic AV rings. And the neonate was on beta mimetics and was discharged home on those beta mimetics and needed pacemaker at 3 months of life. Just because the heart was bigger than it was, so the electrophysiologist decided that it will be more safe for the baby. But we achieved, first of all, we of course have to think what mistake we did. There are no consensus as we know. And the benefit for this baby was that the pacemaker was not necessary in the neonatal period, because it's well known that there are much more complications when the pacemaker is needed in the neonates that even in the early infancy. The baby is 1 year of age, almost 1 year of age at the moment, in a very good condition. So mother is very happy she is a baby girl. So in conclusion, in majority of fetal bradyarrhythmias, treatment is not necessary. It is important to think about pregnant women with anti-RO antibodies, as there is no consensus if you should treat them or not. However, I am almost absolutely convinced that if we see fetal bradycardia and we do not know the cause, I think that we should do antibodies immediately, but even before, we should give the intravenous steroids based on this one case we had, because some case reports are promising. And it's important as well to cooperate with rheumatologists, because it can be important to treat the mother properly before the pregnancy. I didn't touch the long QT syndrome because, first of all, as Lisa showed, it's not very easy to diagnose but there are more and more data how we can diagnose long QT syndrome. Of course, we do not treat just fetal bradycardia, but if we will have ventricular tachycardia, then we will have to think about the treatment. Absolutely, we should teach everybody that if we have the fetal with sinus bradycardia, each baby must have ECG during the early period after delivery. And I invite everybody to Slow Heart Registry, because I hope that based on this, we will be able really to convince people if we need to treat the fetuses with and mother with autoimmune complete heart block and with antibodies, because until now we do not have the consensus. And I am very grateful to Edgar Yegi, who is the author of the Slow Heart Registry, and I'm one of the person from APC who is responsible for this. So if you have any questions about this, don't hesitate to ask Yegi, Dr. Edgar Yegi, or myself. This is my email, and thank you very much for your attention. And once more, thank you for the invitation.
Thank you so much, Joanna. Before we go into discussion, what do you want us to know more about the registry? How could people contact you? And what's your protocol for that?
The protocol is quite long, so you know it was not time. But if we have time at the end, I will just show you briefly on the slide. But I had to put them on the slide, so I can do this by the end of our webinar.
So basically, any fetus with bradycardia below, what is the
definition? No, these are all only for the mothers which confirmed anti-RO antibodies. It's only for immune.
So bradycardia. What's the definition of bradycardia? Is it less than 100 or less than 120?
There is no definition of bradycardia. I mean, I based on this article from 2012. When there is, I will show this. Oops. Wait a second. Yeah, this one. And I think that this is really a very, very good, because it was based on the fetuses from mother from long QT. And we see that 140, even 140 in fetus in 20 weeks is low. So I based on this.
Okay.
In suspect that the fetus, I think it's better to check those fetuses. First of all, the mother must have positive anti-RO, yes? And then if they have positive
Only anti-Rho, anti-La, or any autoantibodies like sugar and
oriented, no, and on SSA,
only anti-Rho,
SSAD.
only
No.
anti-Rho, anti-La. Okay.
LA or RI. I will show by the end because I didn't put this, but I have the protocol, so you will know.
Thank you. Lisa, I can see that you wanted to talk. Lisa?
Oh no, sorry. I would use the normative data as Joanna was alluding to diagnose bradycardia. You could see from even the work that Bettina and Jeanette had done on long QT that those babies actually largely that ended up with long QT confirmed presumably by fetal magnetocardiography and also after birth were largely ones that had sinus bradycardia that were less than, I think the third centile was what was used in that paper. So that's where I would do it. With the heart block, most of the time it's much lower than that. But when we're talking about sinus bradycardia, I think using normative data is really helpful.
What is the definition of bradycardia? Is it less than 100 or less than 120?
So Rima, it's using normative data. So just like we would say, what's an SGA baby, you use normative data, or fetal growth restriction. So you need normative data because heart rates change with gestation. You need to use a centile as opposed to, or a Z-score or whatever that is related to that gestational age. Otherwise, there's no cutoff. There's no absolute cutoff.
This is very important. Yes, Janet, sorry. Yes.
I was just going to say, I think what Lisa said is very important because if you look at Bettina's data, our data from the 2013 CIRC paper, about 2/3 of those fetuses with long QT would have been missed if you used the standard obstetrical definition of a rate less than 110. So I think what we've really changed now is that we're using there's a number of different nomograms. I like the one by Serra et al., SERRA. It's 4,000 patients. It doesn't look like the one that Joanna showed where it's sort of straight across. I think it's pretty much like the Mitchell data. And I think when you look at those, if you have a heart rate of 135 at 20 weeks gestation, that's abnormal. So I think that we have to start training obstetricians to be looking at gestation-based heart rates as opposed to pure rate base.
So is this the trick here is the variability of the heart rate, of the low heart rate, not the absolute number? Is this the message? Because I think from Joanna's cases, there was the rates were variable. We're not, I mean, you're trying to, you have, what we heard is that she has a strong feeling that this baby is not well, and then the baby did not become well, but we don't know the numbers that I mean, you're all world experts, but for just general obstetrician or MFM or fetal cardiologist, what is the advice? I mean, it's 124, 125. Do we go to nomograms for gestation? Is this the message here? Go for nomograms, and where are these nomograms available?
We could certainly post that after the conference, some references for the audience to utilize.
Great, thank you.
So I think it's really a prevailing heart rate. It's not just a single number. It's really a prevailing heart rate. And oftentimes we do recheck this to be sure that it is bradycardia. But in general, most of the normative data has been with CTG, which is sort of an average overall heart rate.
Yeah, this is the importance. How do you, I mean, Joanna, you've done a lot of CTGs references. I mean, we as cardiologists, we don't look at CTGs, we get referrals because of CTGs. Is this correct?
Yeah, I showed you CTGs. I know that we are cardiologists, we are not looking at this,
but I think
I have been working with obstetricians for a long time. And I really had to fight with them to stop doing cesarean section due to premature atrial contractions. After one baby died because was born many years ago in 30 weeks of gestation, and it was completely it was completely stupid. And I said, look, it is just 60% of sensitivity and specificity. You can't rely on this. And then they started to think, because everybody were furious. And then because for them, fortunately, rather for old generation, because younger people, they understand that the CTG is something completely different. So if they see the at the moment, the CTG, let's say around 100, yes? And the normal ultrasound, they fortunately send the fetus to the cardiologist. And I think this is our job, to teach obstetricians that if they see, let's say not 100, but 130 in mid-gestation. Yes, because we don't like fetuses with 130, fixed 130 in mid-gestation. It is something wrong with them. I remember my really almost fighting with my obstetric colleagues with this fetus I showed you with first degree block. And I thought, see, this fetus had bradycardia. And she said me, no, 120 is completely normal for the fetus. He said, no, it is not normal. It is safe for the fetus to survive, but it is not normal. And this I understood when I really searched for the articles. They had to have their basis for safe delivery, yes? And for them, this 110, 120 is okay because the fetus will survive. But this is not normal for us because there are very many underlying conditions like anti-roll, like long QT, and so on. So at the moment, I'm teaching obstetricians, just don't stress the mother, just send them for cardiology and we will tell what to do. Especially that I think that we have really possibility basing on many and Bettina and Kune and yourself interesting papers that we really can diagnose long QT in utero, and then we can save some of baby's life, yes? And it's life-threatening disorder.
They can because they have magnetography. That's easy for them to diagnose long QT.
No, but we can, but there are some very interesting papers. How can we use
I hope to be able to
echocardiography, you know. We are at the moment we are in fetal bradycardia. Apart from AV time, we are really looking very carefully for IVRT, and if it is prolonged, if it is longer, we do not have data, but if it is close to 60 milliseconds, we try to monitor those fetuses. Are we right?
Yes, I wanted to just make some comments in my own talk about the future of MCG, because I think it's really just around the corner. I know you've heard me say that for 20 years, but it's really true. We have some new and interesting aspects of the rollout of MCG that I hope to be able to tell you about.
Right.
Oh, but just going back to the Janet and Lisa, because I think this talk of the treatment, to treat or not to treat, the message is here to the audience, because first of all, hints to diagnose long QT without magnetography. What are the hints? Bradycardia is one. What else?
Yeah, I'll go through that in my talk, Rima.
Okay, great, thank
But
you.
I do want to make one comment though about the importance of recognizing early recurrent SSA in a mother, because Ismerly's data suggests that if you use hydroxychloroquine beginning at 10 weeks gestation, that you can cut the recurrence in half of heart block in patients who have SSA. And I think that's an important thing to bring up, is just, you know, have you had any experience with that, Joanna, in using hydroxychloroquine in your population?
Yeah, and we, since it started to be used, certainly we had less number of fetuses with complete heart block. So
sorry, so the recurrence, mothers who, let's make the statement clear, mothers who have anti-Rho, anti-L positive, so it's SLE with phenotype or no SLE, just antibodies positives, and had previous babies with heart block. With the next pregnancy, the recurrence rate, I don't know, is it 10 to 20%? So you want to put her on hydroxychloroquine.
Majority of them are put due to their symptoms. And at the moment, Polish rheumatologists prefer this than steroids because it's less side effects. And I think that the final effect is much better.
Throughout pregnancy,
we are just gathering our data for 20 years. So I hope that we will be able to show really the benefit of this drug.
Lisa, do you want to say anything?
Yeah, absolutely. I'm just putting some information in. There is a paper that's just come out of the Journal of the American Heart Association that Edgar spearheaded, and I was a second author on with one of his fellows, involving several North American programs where we've routinely used DEX, and in a fairly large proportion have also used IVIG early on. And while once you have AV block, we haven't seen a lot of improvement in conduction disease. I showed you the one case where there was clearly progressive conduction and dysfunction, and the baby had resolution, but several of us have seen that. So even potentially preventing the evolution of heart block. But once you have heart block, complete heart block, we haven't seen very much in the way of improvement. But improved fetal, newborn, and even longer term outcomes. It is worth looking at this paper. It's not perfect because it's a retrospective kind of registry that we went back and looked at our experience. And then Edgar compared our experience with these several centers with big experience in Europe. And Joanne, I think you've been a part of some of those, as well as Lynn Lopez's experience and others. It's certainly worth reading because it gives
What
you—
is the message? What's the message in the paper?
At the end of the day, again, improved fetal, neonatal survival, as well as in at least one study that had longer term outcomes, reduction in cardiomyopathy long term for maternal autoimmune mediated heart disease.
Okay. Janet, do you have any comment? You're going to talk about the treatment anyhow, so should we delay?
I would totally endorse what Lisa said. I think that was a very important paper. It just came out this last year. It's I think it's the first time we've really heard a benefit of using dexamethasone in the presence of third degree AV block, which oftentimes centers are not using it with third degree AV block. But I think the idea of being able to reverse the cardiomyopathy and to potentially even reverse some of the block that's there. We have used it synergistically with the use of vitamin D. You know, one of the studies out of Scandinavia showed a higher incidence of heart block in the winter months when the peak times of vitamin D deficiency occur in pregnancy. And in our state, 65% of women are vitamin D deficient. And we have definitely found that the use of vitamin D is synergistic with a lot of other treatments, not just for heart block, but for ventricular tachycardia and other things as well.
IV or what? Or oral?
Just oral, usually in high dose.
Yeah. So what is your dose? 8 milligrams twice a day?
Oh, no, that's the dexamethasone. I'm talking about the vitamin D dose would be somewhere in the range of, 4,000 units a day for a very low vitamin D level.
No, I'm talking about the DEXA, because Joanna gave IV to her patients. And this is very interesting because we had, I think Joanna had complete resolution and then it went back again, right?
I must tell you,
it was IV
we were evolving in our treatment. The first case I showed you, the mother received the dexamethasone orally because we were using it like this, and it didn't work. So then we decided to do it intramuscularly, like for the preparing the baby for premature delivery. It used for a short period of time, but not completely. So then we decided, okay, might be changed it and use it intravenously. It didn't work as well. And after those that we saw that, from the sinus rhythm, we were obtaining the complete block, we said, no, it's not possible that we can't do anything. And after those bad experience, we decided to add immunoglobulins. And then I think that we did the mistake with these fantastic results that we stop steroids too quickly.
Lisa, do you give IV steroids? I know that you give immunoglobulins.
Oh, not IV. I mean, IV was just for preparing for immunoglobulins. And then we are for prolonged during pregnancy, we give orally.
So we've used oral DEX since 1995 or 6 when I went to Toronto. Edgar came to be a fellow in late 90s, and he and I worked on the heart block data. And we clearly showed, even in a paper published in Circ, I think I can't remember the year, but Edgar was the first author. He was a fellow and had then taken on after I'd left Toronto. And we pulled all of that data looking at clinical outcomes. And even then, we were already seeing less cardiomyopathy. We were seeing much fewer cases of this really bad end of the disease. We had also just started using IVIG, which I had done in like 98 with the first patient where there was clearly myocardial stuff going on. The baby had dysfunction. And I asked Lee Benson what he would do in a cardiomyopathy or acute myocarditis, I would say. And he'd say, oh, we'd give IVIG. I said, fine, we'll start giving IVIG. So we started giving IVIG, and we've seen less, for sure, myocardial disease, especially where there's been echogenicities that suggest endocardial fibroelastosis. And we routinely use oral. If it's early enough, we start at 8. We start with higher dose, and then start going down by 1 milligram. So 8 milligrams a day, and then within 1 to 2 weeks going down to 7 milligrams, the next week 6 milligrams, and slowly go down to 4 milligrams, stay tight for a little bit. We don't have good data for that part, and exactly how, what's the minimal amount you can give that has the effect. We don't know that for sure. With IVIG as well, there's a lot of discussion about how much IVIG. I don't like to expose the moms a lot, so often I give them 1 dose, maybe 2 doses. Edgar Yagi would push 4 doses over every couple of weeks. We've not done that yet. We've seen a lot of similar outcomes, so that still needs to be fine-tuned. But there's no question in our mind, and one of the reasons we've sort of fought off doing a randomized trial on RCT is that we've seen improvements with us, and we've seen cases where we know we're heading in that direction because they were developing all this stuff, and everything did get better. With the exception when they get to complete heart block, it's hard to resolve that. I think there must already be so much damage that it doesn't resolve.
So here, I mean, in cardiomyopathy, I mean, I know that you always said use immunoglobulins and steroids. Now, the message here is with the you're trying to catch the early heart block, the early damage in the autoimmune disease. So when and the numbers, I mean, do you go for prolonged PR interval? What numbers? As Joanna was saying, 150. I remember Bettina was saying 20 milliseconds. And when would you go in and start? This is an important message because you get. I've seen a patient with prolonged PR interval, and she had steroids, and she converted to sinus after the Diagnose.
It's a great question. The problem with it is that, and Azaria Ryan did this many years ago. He published in Circ in the early 2000s, all these moms who had autoantibodies, prolonged PR, and they were prolonged 150, 160, 180. None of them were really long, and they all got better. And then Edgar came along and wrote a paper showing that, in fact, in a lot of these women who have autoantibodies, a lot of times their babies go through a transition where they have prolonged PR, but not massively prolonged. And so, and I actually had reviewed the original study and was worried about this. There are other reasons you can have prolonged mechanical PR, right? I mean, there are other reasons. It may not just be an electrophysiologic reason. It may be ICT.
But these are positive antibodies.
No, exactly. But you don't want to treat until they actually have disease. And you may be treating something that's not disease yet. And so what Edgar, and I think Jill's also had cases, Bettina's had cases, where the mechanical PR is more like greater than the 3rd centile, much higher and progressive. Those are ones, or where there's any additional conduction disease. So like I said, I had the case with Wenckebach, or where they've gone to 2 to 1 and you're catching it early. Those are ones in which I would definitely treat. I would not routinely treat any with greater than, say, 2 standard deviations above the average, because they could be normal autoantibody positive moms whose babies have that little transient bump in their AV interval. So we
also say that the correlation goes with the level of antibodies, right? Higher than
even then. I mean, in our maternal autoantibody study that was funded by March of Dimes, we screened about 15,000 pregnancies in Toronto, Earl Silverman and myself, and found like 3% of women had high antibody titers, and most of those were clinically asymptomatic. And yet we didn't get one case of heart block in that cohort of pregnancies or in that population of pregnancies. So it just tells you that there's still more to be understood about this disease. And we're not convinced, and this is, Edgar would say the same, that just a little bit of a high AV interval duration is enough to be treated. You wait until they actually have more disease, and more disease greater than the third centile. It seems like, or third, yeah, I think centile was the cutoff we've seen in our case. He's had cases, Bettina's had cases, Jill's had cases. That's probably where you're really getting into real disease. We also see it in the congenitally corrected transposition. When they have real AV conduction disease, it is not 160. It is 190, 220, much higher.
You don't want to go there. Lisa, the idea of the whole thing, I've listened to Bettina, and I think Janet would probably would comment. You want to catch them early. The idea is that that's why you get them at 18 weeks. You want to treat early. You don't. I wondered the case for.
But you're over-treating. You're over-treating.
Reversed and came back again to complete heart block, which is very interesting.
But you're over-treating. You're over-treating if you're going to treat everyone with a little bit of a prolonged AV interval. And there's some downside to using
stop block
steroids.
trial. Lisa, I think the stop block trial actually only treats second-degree block. So I agree with you entirely. I think treating first-degree AV block, unless it's 5 standard deviations over the norm, which would be around 170 milliseconds or greater, is probably not worthwhile. But certainly treating early and getting IVIG to those that have, second-degree block in the first few hours can potentially be beneficial. That's the premise of the NIH-funded stop block trial, and physicians can refer to that trial. It's on the clinicaltrials.gov website. So in addition to Joanna's trial with the group in Toronto, I think that's another valuable trial that will help us understand whether or not it works to treat early and aggressively with IVIG. But I'm personally a firm believer in the use of steroids in heart block at any degree.
And I apologize, it is third standard deviations above. I don't know what I was saying percentiles. I was back on the heart rate bit, but there's three standard deviations, and that's what we've seen.
The message to the people here, the message to the audience from the experts here: go slow on prolonged PR intervals, right? But bring the patients more regular, and once they start having second-degree heart block, start treatment and strong. Then they get steroids and immunoglobulins for the best outcome. Is this correct? Is this the message that you agree to? Now, going back to Joanna at the bottom of the last thing, saying most of bradyarrhythmias don't need treatment. I'm not sure if this is quite accurate.
I think that yes, because if we have blocked premature contractions, which are the most common, we do not treat them. If we have sinus bradycardia, even caused by long QT, majority of them do not need any treatment in utero, apart from those cases who probably suddenly will be kept having torsades at the point, yes, which not always is very easy to detect the ventricular tachycardia from supraventricular tachycardia. So I don't know how to treat them, and I don't know if we really, I don't know any case from my experience that we needed to put the fetus on beta blockers due to long QT, diagnosed or suspected. So I don't think so. The only situation which we should treat really, this is bradycardia secondary to immune block, or of course bradycardia which caused the fetal heart failure in cases of fetuses with complete heart block. But from my experience, fetuses tolerated quite low heart rate, 50, 55, and I was not talking about beta mimetics, because I think that really we should put the mothers on those drugs as late as possible, because they have many side effects on the mother, not unpleasant side effects. And the fetuses, unfortunately, they of course respond very quickly, but then they stopped responding. So I always, I think that they are more safe if they even have the slower heart rate, but if they start to have the heart failure, like really big heart, like valve insufficiency, then I will have time to put on the higher dose of beta mimetics, and then will not just, accept those doses and stop responding. So
Just
this is my policy.
we have to rush. So both of you, the other Lisa and Janet, do you agree to the statement that most of fetal bradyarrhythmias will not need treatment?
I think Joanna brought up one important thing with regard to premature atrial contractions, though, and that is the fact that they do need to be observed. And a lot of people are unaware that the presence of blocked atrial bigeminy actually increases the incidence of SVT from 1% to 10%. And it may even be higher than that. Some of the studies have shown it as high as 14%. And in our experience with those who have prolonged blocked atrial bigeminy for over a month, it's as high as 50%. So I think that those patients definitely need to be seen back if they have blocked atrial bigeminy or very frequent ectopy, as Lisa mentioned. They don't need to be treated, but they just need to be followed.
So the message is monitor the PACs and the blocked ones, specifically the blocked or both?
Probably both.
Both, okay. Lisa?
Yeah, no, I fully agree. I agree.
Okay, I think we have to move to our last but not least speaker, and this is Professor Janet Strasburger. And I've always wanted to see you and meet you because I've loved the magnetography story, and I know that you are one of the heroes of the magnetography.
Wait, thank you. Hang on,
I'm very, very honored to have you talk to us today, Janet. Please go ahead.
Yeah, I'm working on my slides here. Just give me a second. I have to share my slides real quick. And I'm going to focus my talk, since we are over time, and into two specific areas of importance. Can you see the slides now?
Of course, but please do the presentation mode.
Okay, so so many of you know that we have been involved in NIH-funded research for the past 20 years, looking at bringing along technologies that will help us essentially bring the ICU type of monitoring to the fetal labor and delivery suite. And so we first used squid magnetometry, but it was very expensive. And now we're using optically pumped magnetometry, but it's necessary that I tell you that it's not yet FDA approved for fetal application. So in Wisconsin, we've worked with a number of companies around the United States, and we're also now collaborating with a group in Munich in Germany, Annette Walker's group, and they have an MCG system, an OPM system that's they've recorded their initial 5 or 6 cases so far. So I think it is possible within the next year. We hope that we will be testing the final prototype of OPMs and getting it FDA approved. This company out in California called Applied Physics Sciences Systems, they are making a prototype that's just recently received funding from the NIH for $1.5 million. So we think it won't be long before these devices will be sold worldwide, but probably another year. This is what the Squid device looks like. It's a big, monstrous device that hangs from the ceiling, but it doesn't actually emit anything. A lot of people think it's like MRI, but it doesn't actually emit anything. It's more like an ECG. But it's expensive because it requires helium for the cryogenics. OPM, however, these are the sensors that are in sort of a hand-built holder device. The OPM sensors are inexpensive. They're about 1/10 of the cost. It should be possible to put a system in place in most fetal care centers for about the cost of a fetal echo machine. And I think that that's fairly realistic and probably will be true within the next 2 years or so. it does require shielding, and the shielding is not to protect the patient. It's actually to eliminate a lot of external noise. So you can see 3 layers here of the shield, and this woman slides into this either prone or supine, depending on the devices. While I have time, I just want to point out 2 manuscripts that are coming out that really show the importance of FMCG, both in congenital heart disease and cardiomyopathy, as well as in arrhythmias. So in this one that's just out now, we found that there was a 45% major change in diagnosis with FMCG, which was either new or additional unrecognized diagnoses for a given patient that were evaluated. This was based on 33 patients with congenital heart disease. Of those, 10 of the 33 had a QTCs over 500 milliseconds. 6 of them had congenital complete bundle branch block, and both of these impact survival. Some of them can be treated, especially if the mom's vitamin D deficient. And this is coming out in JAHA in the next month or so. We found that in 81% of the cases, that there was a change in diagnosis for arrhythmias, and 56% of these were what we considered critical, meaning that it changed the long-term prognosis, the treatment, or the delivery location or surveillance amount. And of those that were with the change in diagnosis, some of them were complete reversals of diagnosis. For example, a case that was sent with second-degree block that turned out to have torsade, or a case that was thought to have blocked atrial bigeminy that had, second-degree block. So in 24% of the cases, we found that these were critical changes in diagnosis. So I want to focus just on 2 things today because we're short on time. The first is, how do you recognize torsade de pointes if you're an echocardiographer and you don't have the ability to send the patient for FMCG? I think the importance of this is that it can present any possible way there is, from sinus bradycardia to second-degree block, tachycardia, ectopy, family history. One of the important things is that if there is a family history, I'll go through how frequently we see torsade in the cases that are referred. But oftentimes, a torsade is associated with high drops. So if you have a high drops case, even if you're not seeing anything specific for torsade, it may be worth evaluating. There's usually an irregular opening of the semilunar valves, and sometimes the valves don't even open at all. And so as a result, it looks like the rate is pretty normal. It might appear irregular, but it doesn't appear like a tachycardia. There's usually a variable systolic flow velocity out of the heart, and there's often AV dissociation. And then with sinus bradycardia, it's and second-degree AV block. These are commonly seen with commonly seen with long QT syndrome and maybe a tip-off. And when we see these, for example, with 2-to-1 block, when we see that in a family history of long QT, there's at least a 50-50 chance that the fetus also has torsade. And rarely you'll see atrial flutter, and the importance of that is that usually it sort of misdirects you to think that you're seeing SVT instead of VT because of the flutter, because flutter is so often associated with SVT. So this is just an example of an outflow velocity. You can see it's not very fast. These are the ejection times from each of the marks here. And so you can see the big takeaway is that it doesn't look like tachycardia, but you can see from the tracings here that in some cases the rate can be very fast. Here it's a rate of about 180. Here it's second-degree block. So I think the importance is when you see these very unusual patterns to think about this. This is an article that I just reviewed for Jackie P, and it's coming out, I think, this month. And it shows what they saw with the group in Arkansas with a case of SCN5A, and they see irregular ejection times, not so much as the prior case, but I think when you start seeing these patterns that are highly unusual, think about torsade. And this is the postnatal on that patient. You can see there's some second-degree block here. And then this is a somewhat monomorphic VT. I think a lot of times the torsade in the fetus looks both monomorphic and polymorphic. And here's just a heart rate trend graph over about 4 minutes here. And this is the second degree block. The rate's around 75 or so. A lot of times when you see a rate go from 75 back to a normal rate of 150, you think of it as being sinus, perhaps sinus with ectopy. But in fact, this is all torsade, except for this here and this here. This is all torsade. And so think about torsade when you're seeing a transition from second degree block back to a more normal rate. The importance of it is these rates are not that fast. And this is just the signal average showing the T-wave alternans in this patient. And this is just another case where you can see the torsade here over 20 seconds, the very prolonged QT interval. Most of these fetuses will have QTCs of in excess of 600 milliseconds, sometimes as high as 700 or 800 milliseconds. And many of them are in torsade much of the time. It's just that, again, by echo, it doesn't look like tachycardia. So what is the likelihood of torsade based on our experience with patients? This is from Strand et al., our experience with 39 cases of fetuses referred for long QT syndrome. In the familial group, which was 2/3 of the patients, only 14% had torsade, and none of those had mortality. All were treated. This is 9 cases total. We've since seen 2 more cases. The de novo cases where the fetus is proband, those actually have a higher, those actually have a higher incidence of torsade and a higher mortality, but we're only beginning to learn how to treat these patients in utero, and I'll go through some of the treatments in a second. And then with the non-isoimmune block, I mentioned already that if there's a family history, 62% will have torsade. And so think about torsade even if you're not seeing it by echo, because it may be there. For LQT1, it was not nearly as common, but we did have one patient with a double mutation. The patient had both LQT1 and LQT2 and did have torsade. But for pure LQT1, we don't usually see it. 38% of those cases with familial LQT2, actually that's not true, it's familial and de novo. And then 67% of those with LQT3 had torsade du pont during their FMCG. And with the rare ones, again, a high incidence of torsade. So I think I'm going to save this, Rima, for the next time. This is just a case of monomorphic VT. I'm going to go down. I want to switch gears and talk a little bit about the treatment here. So magnesium is really the mainstay of treatment for torsade du pont, and it's considered class D after 48 hours, but certainly it's highly beneficial in the early phases, and the dose is usually the same as you would use for preterm labor. Propranolol has been very effective. It has a better transplacental transfer than other beta blockers. And then, but if you need an IV beta blocker, esmolol is another drug that's been used. And then lidocaine and mexiletine are second line. They've been useful in some cases, but we have had one case of proarrhythmia from mexiletine in LQT2. So it's not uniformly, helpful. The data that I'm showing here is going to be published in the Journal of clinical pharmacology in October of this year. It's from a talk that I gave at the FDA last fall, and the syllabus from that is going to be published in October. So I'm not going to go through a lot of these in detail, but I would say that if you don't have a torsade, you can use other drugs too, like flecainide, amiodarone, or sotalol, but those should not be used in long QT. I'm going to skip over these others here. I'll hit on this, which is the treatment of SVT, because I want to talk a little bit about the postnatal management of SVT. So in Jaggy's study, he found that, and this is from 2011, I think it's references down here, he found that it was easier to convert SVT than to convert atrial flutter. And if you look here, the time to conversion is close to 10 days in some of these cases. So it's not, I think obstetricians often think that you will have conversion really quickly with these drugs, but it's just not the case. It takes time to convert. and to work the drugs up to, to the doses that are effective. For high drops, it's less likely that you'll be able to convert than if there's no high drops. The drugs for SVT, I'm not going to go through these again. This will be published shortly. The one thing I would say is that there's really no role for adenosine. It can be given into the cord, but entering the cord has a high mortality associated with it, and it's just not worth it, because even if you convert the SVT, it's going to just come back, because the amount of ectopy in these babies that reinitiates the tachycardia is so high that really the adenosine is ineffectual. As far as other newer, most of us have used the AHA guidelines for treatment of fetal arrhythmias, treatment of fetal cardiac disease, including arrhythmias, from 2014. But the Heart Rhythm Society is going to be publishing a consensus statement this year on the management of arrhythmias in pregnancy, which includes the management of fetal arrhythmias. And so you can look for that. It's not out yet, but it will be probably within the next 6 months or so. So I wanted to spend the last of my time on the postnatal assessment of SVT, because there's been a recent article by Jaggy's group that I think is a really important one for people to know about. So first, in 1996, we published an article suggesting that maybe not everybody needed to be treated. If they had fetal tachycardia, they might not need to be treated postnatally. And then in 2010, Bonnie et al. From the Vanderbilt group published their experience with babies, just letting them be off drugs after birth if they weren't born in tachycardia. And they found that 58% of them did spontaneously recur within 48 hours if they were going to have SVT. And in that setting, all of the ones with high drops did spontaneously recur. But in those that didn't, they did a TEP, and 7 of those were non-inducible, and they found that there was no recurrence in that group. Now, this is a little off topic, and I put it in this slide just because I didn't have another place for it, but the importance of recurrence is really real. And so in the SAMIS trial, where they were looking at treatment of DIG versus treatment of propranolol for SVT, 79% of those babies recurred by 6 months out, and 67% of those on propranolol. So this new study by Michelle et al. From Toronto showed only 21% recurrence. And so I think that's a big improvement, and will cut down a lot on the recurrence of rehospitalization in this population. So in their study of 66 infants, that's just, I think it just came out this year, 24% of them had SVT in the first 48 hours. And the things that correlated with having SVT in the first 48 hours was a long VA interval, intrauterine conversion that took longer than 10 days, multiple agents, and a neonatal diagnosis of AET or PJRT. Those had odds ratios anywhere from 4.4 to 18 to 1. They had 19 that were non-inducible at the time of transesophageal pacing, and they did actually use isoprel. So these were non-inducible baseline and isoprel, and none of those infants had recurrence on no treatment. So they weren't treated and they had no recurrence. 21% recurrence occurred in some of their cases, and some of the recurrences were up and beyond 3 years of age. So there is a relatively significant late recurrence risk of SVT in the fetus. So they did something really unique, which is that they, during their isoprel, if they had inducible SVT, they tested propranolol. And in the propranolol group, if they responded to propranolol and were non-inducible, they started them on oral propranolol. And if they didn't respond to propranolol, they started them on oral flecainide. And so with that, they cut the incidence of recurrences down significantly. This is just their curve. This is the babies that had spontaneous recurrence. This is the ones that had, I'm sorry, I don't know if you can see this or not, but it's in my way, but the ones that had inducible by TEP, and then the ones that had no inducible TEP. So at this year's Heart Rhythm Society, there was also a paper presented by Dan Very and the group in Cincinnati, and they looked at 2 centers in the US, one that was a TEP center that did TEPs on every baby, and another that was a non-TEP center. And the difference between the TEP center here and JAGI study is that JAGI didn't do repeated TEPs until non-inducibility. He only did the one TEP and tested the drugs at that time, whereas this other center basically tested and tested and tested until the baby was non-inducible, and then they sent the baby home. So what they showed in this study was that the cost of care was higher, especially because of this longer first initial length of stay. But the readmission rate at 1 month was only 1.6%. So it was a very low readmission rate compared to the observation type center that had a 23% 1 month readmission rate. And so they had no adverse events in any of these studies reported. And as a result, I think this speaks for the safety of transesophageal pacing and how it can be used. I didn't mention it in these slides, but I think some of these centers also use transesophageal pacing at 1 year of age to determine whether ongoing treatment is necessary or not. Not every patient gets that, but it is another option. So I think it'll be interesting to hear some of the comments from the other speakers as to whether they think transesophageal pacing plays a role in the management of SVT, or postnatal SVT in babies that present prenatally or not. And I'd be curious what their centers are doing too. So I think I'm going to stop here. Let's see. So just some important takeaways. Fetal tachycardia is not simple. I didn't present all the cases, but really AVRT is just one of many types of fetal tachycardia. Some are easier to diagnose than others. Right now, we're missing 7 out of 9 cases of torsade, and we have to get better than that in order to be able to recognize these cases and treat them more effectively. The treatment after 36 weeks of gestation may be indicated in some of the diseases like VTAC and JET and torsade, because you obviate the patient to a C-section delivery if you don't treat. Some have even been treating SVT beyond 36 weeks gestation, and I'll be curious some of the other speakers' comments about this as well. I know our center does not treat beyond 36 weeks, but I know centers that do. And then I think it's really important that we continue the FAST trial, which is for SVT, Dr. Miyake's study that was published from the Japanese trial. I think this will be the best way that we know how and which drugs to use effectively. There have been some studies that suggest that, for example, flecainide is better for SVT, but those aren't powered sufficiently to really make that assessment. And I think having a prospective randomized trial like the FAST trial and the results of that will be very beneficial. And then I think it would also be useful to have an antiarrhythmic drug registry worldwide for pregnancies of mothers that are on these drugs. So I will submit the questions afterwards too for the audience if they're interested. And that's all that I have today.
Thank you so much, Janet. Really, really very important. And very good news regarding the development of fetal ECGs now, because the world is waiting for something which is less scary than the magnetography machine, whatever. Now, we asked the other audience, our experts, about Janet's questions. She wanted to know about how long do you treat, the SVT in utero? Do you follow patients for 6 months or not? Do you treat? Do you do 24 hours monitoring after delivery? The recurrence risk in your institutions and so on?
Yes, we do. I mean, if of course with conversion to the sinus rhythm, we do, and even if there is no signs of tachyarrhythmia in Holter monitoring, our electrophysiology colleagues prefer to put the babies on mainly beta blocker. But I doubt if you should do this or not. At the moment, you are doing this for 6 months. Usually,
Till 6 months of age, without doing a 24 hours Holter postnatal.
no, with always those children have in the neonatal period. Usually they have repeated in 2nd and 4th months.
So if it is normal, you still put them on beta blockers
Mhm.
for 6 months. Okay. Lisa,
So we,
I know you don't do that, but
Firstly, we do treat even late in gestation, and we've had conversion, and then we're able to deliver vaginally.
why do you treat if late gestation? What are you worried about if you treat late? I mean, the question is that Janet is saying, well, it's no value to treat at late gestation.
No, the primary
No,
reason is
I didn't say
Yeah.
that, Rima.
No, I'm saying probably. So you're holding treatment for late gestations, probably because I don't know why, but I was just saying.
the reason to treat is more to allow mom to then have a regular vaginal delivery. It is not necessarily, it's rare that we'll see them really late be super, super sick. These are mostly ones that have SVT. And so we're treating actually, even though the babies look actually quite well, so that moms can have a regular vaginal delivery, which reduces her morbidity. It's better for the baby all the way around for a lot of other reasons. And then we monitor the babies. So we would treat late, even after 36, 37 weeks. If they're hydropic, we wouldn't spend a long time trying to treat, because if we can get them out of the SVT with delivery, then that's probably the safest way to go. And we're just looking at that. Bettina's pulling our several centers' experience with late treatment. They're pretty rare, but I think that they're of value for that reason. So we've had good treatment.
And postnatal, what do you do postnatal?
So postnatal, we have a routine of a 48 to 72 hour monitoring. With some telemetry, so they're usually in the hospital for that, which is a little bit of an expense. But even whether or not they've been treated, if we do that monitoring, let the drugs get out of their system, and then if they haven't had an SVT, we send them home. We get a Holter in about 7 to 10 days to document whether off treatment they have anything that's suggestive, and if they do, then they get treated. If they don't get treated, but we follow them. So they'll continue to get followed at least through the first year, sometimes through the first 2-3 years, when they can then be like, oh, mom, my heart feels funny, and tell the parents that there's something going on. Every cardiologist does it a little bit differently in terms of how frequently they would do Holters. We send all the families home with a little stethoscope, cheap one, but it works. And they learn how to assess the baby's heart rates. And that's really been like the Doppler tone. And a lot of our families prenatally have been used to the Doppler tone. That's been really helpful. We have a good nursing support that teaches them. They go home. If there's something that changes, they know who to call. So that's how we've done it. And it's about 20% that will have a recurrence postnatally. I find a lot of the EATs seem to go away more often if there's not structural heart disease, more often than the AVRTs, but the AVRTs too, sometimes you don't see them back, right? And the atrial flutters, most of those we don't see back. The ones that are harder to treat prenatally, we certainly had trouble treating them after birth, so we don't feel so bad.
Let's make this advice simple to the audience. Now, you've said 3 or 4 things. Now we're talking about the what you said, simple supraventricular tachycardia, and then other types of supraventricular tachycardia and supraventricular tachycardia with hydrops or no hydrops. So what Janet said with the hydrops, probably there is a higher recurrence risk than no hydrops. Is this correct, Janet?
Well, that was just one study. I think Dr. Jaggi's study did not show a difference in the hydrops in terms of postnatal recurrence. And so it may be study to study.
We wait to treat because we like to see what the mechanism is. And then depending on the mechanism, although you often will jump to propranolol, but what we don't treat until we see what the baby has, because some of them just never recur. So to put them on a drug for many, many months without having documentation that it's going to recur, and we don't do testing. We just haven't had the resources to be doing the TEP. We did it when I was a fellow. But since then, I haven't seen it done in any of the centers routinely.
The question, do you stimulate them? That's what Janet was asking. Do you try to see the arrhythmias postnatally?
So we haven't routinely done it, but we've had surveillance, Holters, and clinical exams, and the families have a stethoscope that they assess the baby with.
So my understanding is that everybody agrees to doing Holters postnatally. right? From the
Well,
panel?
I think it depends on the center. The centers that are strong in electrophysiology have the abilities to do transesophageal pacing. And I think in that setting, at least some of these patients benefit from having that, because for one thing, you can identify a patient that doesn't need any drugs. And you can do it without a risk of them coming in the ER in SVT. So I think in the centers that train, they should be training more people to go out to other centers to do TEPs, because I think there is a rationale for using the transesophageal pacing. It's relatively straightforward. It's non-invasive or minimally invasive, and it's safe even with sedation. And all three studies, actually multiple studies, have shown that it's safe. So I think it's probably underutilized, and I bring it up as in this discussion forum just for that reason, that I think it's worth taking a relook at this. You know, could we identify a patient that doesn't need any treatment at all, or even for that matter, any follow-up at all? Because none of the ones that have been tested negative with isoprel and baseline have had any recurrence.
So
Hey,
would you,
but, you
so
know,
would
on
you
the
do
other
that
hand-
if you did EP study and you found no recurrence, but it was a baby who was hydropic prenatally that you treated? Would you follow that baby?
Well, yeah, I think, I was sort of tongue in cheek when I said no follow-up, but I mean, I think, would I follow that patient the way I would follow a baby that was, say, 48 hours out and you're sending them home and you don't know if they're going to recur? I think those babies are getting pretty elaborate follow-up, and it's costly to do that. Now, interestingly, I don't think we've had the true test of the cost of this, which would be to do Jaggy's protocol in one center and not and do an observational in another center and see what the cost of care is, because there's a cost to the patients for missing work and readmission on an unscheduled basis, hospitalization, starting drugs late. There's a cost to that too. So it's not totally free to avoid a TEP in the beginning. I'm not arguing necessarily that every baby needs a TEP, but I think there's certainly a role, and I think the centers that are strong in EP are probably going to be the ones that use it more often.
Well, so that we have to send a message to the audience, because we're talking to the world, and not everybody has a electrophysiologist in the house. And so what is the safest way of dealing with fetal SVTs postnatally? I would suggest that we have to categorize them. If it's an SVT that responded easy to treatment, SVT that had double dose of medication, SVT is not like AET or flutter, whatever it is. So we have to go back to the diagnosis of the original mechanism. And if there's another thing is structural heart disease, no structural heart disease. So could you help us, send a message to the audience? How would you follow, and how do you follow? Because of cost effectiveness, most babies are discharged after delivery, 3 days or 4 days, depends on the hospitals, on the insurance and so on. So Europe and States and Middle East is different. So would you tell them, okay, they can go home and come back, or no, I will, depending on the resources, I will do a halter and then ask them to come back in a week or 2 weeks and then follow up to 6 months. Lisa is saying up to 2-3 years. Can we reach a consensus? How would we follow up such babies postnatally?
Well, I would say that every baby who has intrauterine SVT should be evaluated postnatally by a pediatric cardiologist, and in that setting should be observed for at least 2 days in the hospital for recurrence, and should be closely observed in the first week. And that, like Lisa said, probably includes a Holter monitor. And if they can have a transesophageal pacing, then that should be done. If they can't, then observation is important. The observation should go beyond 3 years out, because these babies are at risk for recurrence of SVT. I think Jaggy's data suggests that there's a significant risk, in that there's been other studies as well showing as much as a third of the time these babies will have an episode of SVT by at least adolescence. So I think they shouldn't really be discharged completely unless they've had a TEP that's negative and an observation period of probably 6 months or so. And then I think they're probably not going to need any follow-up after that if they are TEP negative and beyond 6 months out.
So if not done, then you bring them up to 3 years. When they come back with ECG, and a strip rhythm or a halter? Follow up.
Well, I don't think it needs to be a halter necessarily, unless it's in the first week or so. I don't know, Lisa, what's your thought on that?
There's some differing opinions in our group. We don't see them a lot in the first year. It's sort of like we see them after their first halter, which is, like I said, about 7 to 10 days, because that's often where we've seen them recur once they've kind of had the drug out of the system, and these are the ones that are treated. So we do the 7 to 10 days, follow them up at 2 to 3 weeks or so clinically, you know, having the halter data to talk with the family, make sure that they are comfortable. Like I said, we send them home with the stethoscopes. Usually they're not seen again until they're more like 3-4 months. And then after that, it might be another 6 months. Like, they're not seen all that regularly. Beyond 2-3 years, we leave the door open, but we say, you know, this is what you're looking for. If the child is doing anything funny or saying, ow, you know, it's when the kitty's able to kind of let the family know. And we always have an open door. I've brought a couple kids back in where there's been concern, and for one found SVT and the other didn't, you know, so like, as long as you have an open door, I think that's really important, just in case it does recur.
But you would not bring the baby to the big hospital if the, say, outskirts, so you would accept the ECG read by the local pediatric cardiologist, and then if there's anything, they can go back to sick kids or whatever hospital they're in. Because
well, ours get delivered in our hospital. It just is a centralized. So wherever they're coming from in northern Alberta, they get delivered in our hospital. Their follow-up is either in our hospital or in one of our outreach programs. So we have
so you keep them under your and Janet and
yeah, that's true. That's true for us as well.
You keep them. Yeah,
I was going to ask you about EAT. If you how you would, because obviously you're not going to use TEP anyways necessarily for EAT, right?
No, and I think according to Jaggy's data, those were the patients that spontaneously recurred within the first 48 hours. And when I say 48 hours, it kind of depends on which drugs they were on prenatally. If they were on amiodarone, it's probably not going to be 48 hours. It might be a week out. But you have to assess what the half-life of the drug is that you're withdrawing the baby from, and whether the mom got it right before she delivered or not, or whether it was stopped at earlier than that. But generally, you have to make sure that they are at least 4 half-lives out from the drug that they were taking. I hope
that's very important. So based on the medication, you keep the baby postnatally. If it was just a simple digoxin or whatever, you would wait for 3 days and discharge. If it was other amiodarone or flecainide or whatever, you would wait for, let's say, 3 half-lives. Let's say 3 half-lives of the medication to discharge the baby. We want something for the audience that don't have guidance.
Well, I think pretty much the drug is gone after 4 half-lives. So I think 3 sounds reasonable. I don't know. I don't think there's any definite on that, but
I think that this is very difficult. When we I tried to find any data, how often is the recurrence of SBT, and there are some data, but not many really. And there are some centers which put babies on drugs, like our center. I mean, our electrophysiologists, because I'm not taking care of those babies after birth. Yes, these are our colleagues who run the part of the department with electrophysiology. We have, number of patients who needed to have ablation later in life. So we know this. And because we use amiodarone very widely, as we do not have flecainide in Poland. So we know that within the first week of life, majority of those children will not have any arrhythmia. So usually they have scheduled in the cardiac clinic in 1 month, 2 weeks, 1 month of age, something like this. Of course, the parents, as Lisa wrote here, are prepared how to diagnose arrhythmia at home, yes, because we really can't predict this. Atrial flutter, I think, is easy, because atrial flutter, this is very rare that it will recur in the infant. But SVT, it's likely. And the other thing is we know that these additional pathways, they are disappearing when the baby is growing. Yes. So this is the very, very, very open story. So I think it is very difficult to really to write the exact guidelines for everybody. I always think that the guidelines should be in the institution because it depends on your experience. Of course, it would be great if we have the general guidelines. At the moment, Edgar Yegi once more, he is leading this prospective and randomized trial, yes, until the second, I think it's until second year of age of the children treating with SVT as fetuses, yes. Maybe we will know something if it's good that we are treating them after birth or not. At the moment, we are treating, but sometimes if, for instance, I have the patient with SVC in, let's say, 24 weeks, and in 28 weeks or 6 weeks, the baby is healthy. I'm afraid of just get rid of all drugs until delivery. But then I think that this baby, if the baby was free for already 4 months, yes, with arrhythmia, the baby will not need any prophylaxis after that, but need to be discussed with the people, with the doctors who take care of those children. So I think that it is still the field for cooperation and for improvement.
The message is controversial if you have, because we're running out of time. If you have babies with fetuses, SVTs, deliver where? In a tertiary care center?
Yeah,
or
in the tertiary center, yes, always.
And then observe for, don't start medication.
At least 7. None of those babies are discharged before 7-10 days of life.
But we will not, some centers would not give medication at all at birth, and then just wait.
At the beginning, we do not give medication because, as I told you, we use
we all agree that just observe and do an ECG. Yeah. And then, Lisa, you want them at day 7 to come back for Holter, so they can go home?
Yeah. Yeah. So 48 to 72 hours, and then they go home.
And why day 7? It's just to make sure that.
Okay. If that's so, it could be 2 weeks out. We just try to do it. We're worried about the drugs now being out of their system.
Okay.
So 7 days was an easy 7 to 10 days.
I started thinking whenever I see an SVT in the emergency, I want to check what happened to this baby as a fetus.
Yeah.
Because
one more comment about the sort of the interim period when you're observing these babies, and that is that there's 2 times that they are uniquely susceptible to getting SVT in the first 2 or 3 months of age. One is with immunizations that cause fever, and the other is with fever due to illness. And so oftentimes that's when we have the moms pay extra close attention to, whether the baby's having SVT. We'll sometimes pre-treat the baby with Tylenol before immunizations just to decrease the pyrogens that trigger the SVT. So I don't know, there's no science to that, but it seems like a good idea. So
I think I quite agree. Just one more protocol from you as experts: diagnosis of long QT without magnetography in fetal life. The hints.
Persistent sinus bradycardia.
Sinus bradycardia is one.
This one which we've already discussed.
I would go for positive family history. I would go with history first. I would go with positive family history first. I think you agree.
All of the above. All of the above.
First you diagnose fetal bradycardia, because if we already examine the fetus with family history, that's okay, yes. But then sometimes we just diagnose fetal bradycardia, and then we have to think about
Okay, so sinus bradycardia, and what else? With structurally normal heart, number 2.
Yeah.
2 to 1 block.
IVRT.
2 to 1 block, yeah. Mm-hmm. Unexplained 2 to 1
combination of tachyarrhythmias with bradyarrhythmias. The combination.
That's very important.
I think this is the most important.
And high drops.
Development of high drops. I know that Bettina treats in utero. Janet, for long QT? What, she gives beta blockers or what? And what is the
We usually
regimen?
start with magnesium and then we'll add a beta blocker. And usually it's an oral beta blocker, but depending on, the gestation, we would treat even close to term just because these kind of arrhythmias are very unstable in newborns. And so if you can get some degree of drugs on board before the baby's born, it's actually very helpful. So that, unfortunately, there's this belief out there that any kind of fetal tachycardia beyond 36 weeks should just be delivered. And that's wrong, especially when it comes to junctional tach or ventricular tachycardia. They should be treated in utero to stabilize the infant prior to delivery.
As Lisa
I
said,
think, sorry,
healthcare
may I tell
doesn't-
something? Because I think that Jeanette told at the moment a very, very, very important message. Because for majority of obstetricians and neonatologists, 34 weeks of gestation is absolutely enough and the baby can be delivered. Might be if it is the healthy baby, but if the baby had arrhythmia and is unstable, it's much better to treat, as Jeanette said, in utero until 38, 39 weeks, because the baby doesn't need to breathe, yes? So I think that this is the message for the whole audience. Do not deliver fetal arrhythmia early.
Yeah, that's very
harm.
So Jeanette,
and it's not
can I ask you something, Jeanette? So if you just have sinus bradycardia and have had no documented tachyarrhythmia, even 2 to 1, whatever, would you still treat then prior to delivery? Because that's important. Would you
No,
treat,
no, I think
for tachy.
I think the big important take home is that torsades is much more common than what people realize it is. So you may see sinus bradycardia, but it may be associated with torsade. And I think that's where you have to think about it. It's often fleeting when you see torsade. It's, 6 or 8 little beats in a row, and that's it. That's all you see. And you might catch it or you might not. And so I think that's where this new technology will be very helpful in, because we're monitoring continuously, just like we would in an ICU. So we would not treat sinus bradycardia, and even if the QTC, if we had an MCG and the QTC was 600, we probably wouldn't treat with anything other than vitamin D and avoidance of drugs that lengthen the QT interval. Beyond 600 milliseconds for QTC, I might consider it, but usually when we've seen that, we've also seen second degree block and we've also seen torsade. So, but, I think the big thing is that these are oftentimes, I think, stillbirths. These are babies that aren't being picked up at all because there's no family history. They're dying at, between 20 and 28 weeks gestation, and they're not, there's no thought that they have long QT, but they do. And the genetic testing shows that about 8.8% of these cases have known, well, at least 3% have known identifiable long QT syndrome, and up to 8.8% have dysfunction associated with the ion channels that's probably related to long QT that's yet to be identified. And the other thing that we've have a belief in is that probably there's a stabilizing effect of being delivered and being in an ambient weighted environment as opposed to being buoyant like you are in utero. So the QTC in most of the patients, if you look at the Strand article, of most of the patients with the really long QTs got better after they were born, sometimes substantially better. So oftentimes it's a matter of just trying to get them to that point where, and the other thing that we've found is that you don't have to have 100% control of torsade. We've managed patients who've remained in torsade 10 to 20% of the time for weeks before delivery, and still had good outcomes. And the more we learn about how to treat torsade, the more effective I think it's going to be.
The other element of having a suspicion of long QT, while the de novo seem to be like a worse variant, is we've had a few that the families have then been identified as having long QT that were completely missed. So it's another, reason to be having that in the back of your mind, not just for this pregnancy, but for other risks in the family.
Yeah, I wanted to address the idea too, Lisa, about high drops alone. So we've recently looked at our experience with high drops referred through my R01 study for babies at risk for stillbirth, one of the categories is high drops. And in our series, combined with our past experience, 100% of these babies with high drops have an arrhythmia. And that's, I think somehow we have to get that across to obstetricians, whether they're expecting an arrhythmia or not. 100% had something. They had a cardiomyopathy with a wide QRS, or they had WPW, or they had, elevated voltages due to some kind of a metabolic disease, or they had torsade. A number of them had torsade as the etiology of their high drops. So I think if we can just prevent the termination of pregnancy of high drops before I would like to see all those patients referred for evaluation before they're terminated, because I think we would be able to find things that are treatable conditions.
With the sinus bradycardia, now back again, unexplained, would you do genetic testing? I mean, is this
We do
part of
not
the
routinely, because it's not possible. I mean, sometimes we do when we have a grant, but not always it is possible. If we have strong suspicion, we do, but not routinely. Not routinely.
You have to do CVS then, right? You have to do CVS for complete genetic, for whole exome, right? Janet?
Mhm.
No, I think you can always, at birth, you can do a cord blood sample and send it for just the long QT panel. That's you can also do a buccal swab.
No, I'm talking antenatally. And you have a case where
we haven't had that opportunity. Dr. Guzman, Annette Guzman Walker has had the ability to do it on amniotic fluid, and in her center in Germany, in Munich, and I think she has been able to make a diagnosis prenatally of HCN4, which is a familial bradycardia syndrome. We have not had the ability to do that, but it is part of a grant that I just submitted to NIH to be able to do genetic testing in some of these more rare cases.
Starting from, CVS or just amnio fluid, 13 weeks, 12 weeks, stuff like that?
We just don't see them that early. I think by the time they get referred to us, they're beyond the point of CVS.
So, amnio. All right. Lisa, do you have any comments before we close? And Joanna, and I'd like to thank everyone, but I'll just leave take-home message from each one of the three eminent speakers. We'll start with Joanna. Joanna, could you kindly give us a take-home message from your talk?
Yes, absolutely. I think, first of all, that as we cooperate with obstetricians, it's crucial to distinguish between the obstetric and cardiac reasons for bradycardia, and the definition of bradycardia for obstetrician and cardiologists is different. Majority of bradycardia is not life-threatening for the fetus, and those babies shouldn't be delivered early. And majority of bradycardia don't need treatment. However, all women in whom we know that they are positive, immune positive for LA and RA antibodies should be really monitored closely, and treatment might be possible.
Thank you. Jeanette?
I just want to say that I think that the synergy between fetal echo and fetal MCG, once it's available in every fetal care center, will be impressive. And I think the two manuscripts that we have coming out will show that. I think what we need to do is we need, as a society, to bring forward MCG in a form that we can get it out to the populace, because right now it's trapped in a physics lab, and it will be until we establish ways of advancing this. And we're hoping that this quantum initiative here in the United States, which is to promote quantum sensor technologies and to get it into medical care arena, will be helpful for us. But I think some of our patients could be advocates on this behalf to bring forward information. There's an interesting article by Kogut looking at technology advancement in obstetrics in 2020. Kogutt is the name, and he showed that obstetrics lags far behind other medical professions in any kind of device development at all. In fact, there's 37 times as much effort put into cardiac device development as there is to obstetric device development. And as long as that's the case in the future, we will go nowhere fast. I think we need to spread the word that this is an important area of where we need advancement.
So the message is we want portable MCGs, right?
Yes, we want MCGs in every fetal care center in the world.
Okay. Lisa, take home message.
That would be incredible, and I suspect the Fetal Heart Society would be willing to support that as a start in North America, for sure. I would second what my colleagues have said, and I think it's a really great field. I think we still have a lot to learn and to continue to fine-tune the care that we provide these moms and these babies. And we've heard today, anyways, areas that require ongoing study to just continue to get better. And we've come a long ways for sure. But I look forward to the future and continue to fine tune, and certainly look forward to having fetal MCG in my practice.
And I think to add to your, I think what I learned from your talk as take home message is that hand-in-hand Doppler and M mode in diagnosis of fetal arrhythmias. And also interpretation of Doppler is very important. And we have to learn how to do proper Doppler, and also that tissue Doppler has a role and will have a more important role in the future. I think so, right?
Yeah, absolutely. And home Doppler devices, I think are really cool because they honestly really help our practice, help where we're resource poor, and provide some a feeling of confidence for the women as well. I think for most of our women, they feel that they have some control over the situation, being able to monitor and knowing they can get a hold of someone if the baby's in an arrhythmia. So,
and from all of us, the message to our colleagues at the fetal maternal and obstetricians, please keep the fetus up to 40 weeks as much as you can. I think that's the optimal goal of the whole fetal cardiology vision. I'd like to thank you again and again. And I'd like to thank our audience who stayed late with us, and also whoever did not get time to watch us today, they can watch us at YouTube. And we'll hopefully listen to your questions more and more with the next episode. And thank you for being with us, and have a very good day or a very good night, depends wherever you are.
Thank you,
Rima.
Bye-bye, everyone.
Rima. Nice to see you guys. Bye, Joanna.
Bye-bye.
And Grace.
Bye-bye.